So we are live in 3, 2, 1. Please start. So we are live.
Hello, hi, good evening, everyone. Welcome you all for this live webinar, Oncology Next, the Future of Cancer Care. For the welcome and introduction note, I would like to invite program convener, Sir Dr. Ankit Batra, sir. Sir is Associate Professor Medical Oncology, Cancer Research Institute, HIMS, Dehradun. So, sir, over to you for further proceedings and welcome note. Thank you.
Uh, Thank you. Very good evening, everyone. At the outset, I would like to welcome everyone for taking out time on a weekday in the evening and contributing to this oncology fest for the Oncology Next, the Future of Cancer Care. So we all know that oncology is changing very rapidly, and we need to upgrade ourselves as soon as we get the newer data. So we have seen a lot of new studies have come in the ASPEN and ASMO. So we are having this 2 day oncology feast, and it will be divided into various subsites. So today we'll be discussing about GI cancers and GU cancers, and we'll discuss four important landmark trials and updates first, and then followed by a panel discussion for the lung cancer, and then followed by the GU cancers. So without wasting much time, I think we should proceed for the academic program. And we'll start with the plenary session, that is the Matterhorn trial. We all know that there is a lot of unmet need in the GI cancers because we have been still struggling with the old age surgeries and the chemotherapy combinations and combinations. And a lot of need is required to upgrade the treatment so that we can improve upon the outcomes of the patients. Because if we talk about our set of patients, majority of our patients land up into advanced stage, and we need something over and above surgery and chemotherapy so that we should go ahead in terms of survivals so that our patient can be benefited more and live long. So to begin that, we have one of the plenary sessions, that is the Matterhorn trial. It is a phase 3 trial of using peri-op immunotherapy, that is durvalumab, along with the standard of care FLOT, and then surgery, and then post-op FLOT plus durvalumab, and then durvalumab maintenance. So to deliver this talk on this abstract, we have with us Dr. Deepak Bhati sir. He is a senior consultant medical oncologist at Sri Mata Vaishno Devi Narayana Super Specialty Hospital, Katra. So I welcome you, sir, and over to you.
Okay, thanks. Okay, I should start.
Please stop sharing.
Yes. Okay, thank you. You all are able to see my slides, and I'm audible, I hope. Organizers, my slides are visible?
Sir, we can't see your slides, sir.
No?
No,
You
sir.
have
No,
to,
sir.
I think, sir, stop sharing and then share again because it's coming, but it is very like it's visible now, sir.
Yes, now it's okay. Now it's okay. Thank you.
Fine. So, without wasting time, good evening, everyone. And thanks to the organizer, especially Dr. Ankit Batra, for giving me an opportunity to discuss a very important topic, and especially it's discussed already in ASCO 2025 meeting. As Dr. Patra has already told, that basically is the need of the hour for better GI cancers. We all know that we start with all the single two regimes and triple regimes and some 5 day DCF and all way wrong with anthracycline is other way around, but we're not able to achieve all the what we want to have the survival benefit of our patients. Then comes the era of immunotherapy. It start with the stage 4, then find its place to adjuvant, then adjuvant, and then the maintenance setting all the way around. And especially if you see the trial which is there initially after surgery, if someone not able to keep the PCR, and then they add capox or something like with nivolumab. So this is the basis of a trial. Then they decide that we can shift the immunotherapy to the upfront setting, the perioperative setting, so that we can increase the benefit of all the PCR and survival benefit to our patient. So based on these parameters and based on these basic points, this trial has been designed with the name of Matterhorn, and it's a well designed randomized phase 3 trials. The FLOT is the regime of choice or standard of care in the G junction or G cancers or is all the sector patients. And with that, they have addition of development can make a change or something which we discuss in the next 10 minutes. So what have shown that addition of durva to float improve event-free survival in all the resectable gastric and G junction adenocarcinoma patients. So more importantly, it is adenocarcinoma. It's not for the squamous variant. So background, we all know that's 1.2 million people die of gastric insufficiency in 2025. Fraud chemotherapy, we all know how we can 2 weekly cycles. Still, after giving all the way rounds, there are certain patients which can badly get progressed on treatment, or certainly just within 3 or 4 or 6 months of treatment, disease come back. Just to cut short the story, we want to increase the survival PFS all the way around so that we can give more and more benefit to patients. So there comes the role of anti-PD-1 therapy, especially durvalumab. So they have added up the thing in the perioperative setting. So keeping these things in consideration, the trial has been designed in this way. It includes all the patients with stage 2 to stage 4A. So it's very important that it includes stage 4A patients also. There's no evidence of metastasis, no prior therapy, good performance patients. All the Asian, Europe, North, South American patients are there. And especially, I want to for Asia, there's no one from Indian subcontinent patient has been enrolled. It's all way around Asia except India. So, what the stratified clinical node positive active with PDL1 tumor full scoring versus Asia versus non-Asia. So, just don't go for the 2 cycles. Basically, what they have done, they have given plot from day 1 to day 15, which is usually will be the other case, but they have taken day 1, day 15, 1 cycle only. So, it is a proper 4 cycles of plot has been given to our patients with durvalumab versus placebo, and good number of patient have been randomized. 948 is touching 400 patients. So, after that, patient underwent surgery, and after that we have given again 4 cycles of flot plus durvalumab, and then followed by 10 cycles of durvalumab maintenance therapy. And then, so what the primary endpoint? It's the event-free survival, which we want to discuss. Secondary, they have included OS and PCR. In certain parameters and subgroup analysis, they have taken DFS also, which we'll discuss in its future slides. So I just want to go with the definitions, which we all know regarding EFS. It's from the time of randomization to event or death. OS, we all know. PATH-CR, no residual viable tumor in the primary site and no that surgery. And regarding secondary endpoints, which are telling us regarding DFS, they have included. It is time to disease recurrence or death with RO resection. So it is not for all the patients. The patients who have after given a treatment post surgery getting the RO resection, they are the one where they have taken up recurrence or death as a DFS into consideration. Okay, so what they want to see that how many patients have taken the neoadjuvant. It is 97 versus 95, almost equal to patients have completed neoadjuvant therapy. 96% of patients completed full flot, full regime. After that, out of 100, 91% of patients had attempted surgery. Out of them, 87 have completed the surgery, and 92% out of them have RO section. So this is a schema that out of 100, 87 patients have completed surgeries, 30% not able to do whatever things will be there, and out of them, 92% have either RO section. So what they want to tell us that whosoever gone to the disease with surgery completion, they are the one who get the RO section in 9 out of 10 times. After that, because we know such a kind of plot and surgery things will be there, most of patients are not able to go to the adjuvant therapy. So this is what they have shown also. From 97% decreases to 77%. So 20% patients have been not able to complete the adjuvant therapy. Out of them, 61 are taken completed fraud therapy. So what they have shown that out of the time after 1 doses, 2 doses, 3 doses post surgery, 10% decline of taking of chemotherapy will be there. That thing might affect the results, like all the OS, DFS, and EFS into consideration. So regarding the baseline criteria, I want to just highlight 2-3 points here only. All the well matched things are there. Just I want to that 90 only 90% patients are from Asia. Out of them, 68% are gastric and 32% are gastric junction patients. 75% patients are non-T4 and 25 patients are T4. And regarding node positive, so touching 70% of patients are node positive. So there's a high tumor burden patients because they are node positive. 25% are T4 disease. And regarding PDL positivity, 90% are having more than 1% PDL positivity is there. So out of them, they have taken MSI also, and only 5% patients has MSI high status. So basically, they have taken a good set of patients. 20% are from Asian population. Good node positivity and T4 disease are there in majority of our patients. So coming to the first primary endpoint, it is a EFS. So they have started the things just to want to see after 2 months curves are starting separating, and well separation has been seen by the time of 1 year, and they have taken first in the 1.5 year, it is 73% versus 64%, so touching 9% benefit has been shown after 1.5 year, and after 2 years benefit is still maintained to 8%, so 59 to 67% only, and after that still they are not able to achieve the median EFS in the Durval arm, and the placebo arm it is 32.8 months. It has a ratio of 0.71 and stratified p-value is there. So 39% mortality benefit has been shown. After that, still not able to achieve the median EFS. Placebo was 32.8, and after 2 years, we can still say that 8 to 9% of patients are getting more and more benefit as compared to the placebo arm. So regarding the just they want to highlight two things, that Durban plot, neither is not even a single parameter they have shown that which is not done better with the Durvam. So whether it is the age, whether it is the sex, or whether it is the Asia, non-Asia, or lymph node positivity or negativity, all the parameters has shown benefit. Even in the PDL positivity or activity doesn't make hamper anyone. So irrespective of PD-L1 status, patients are getting and achieving the benefit in all the parameters of analysis. So after that, there's a more importantly secondary endpoint is the OS, which you all want to see because patients are curative settings. And after 1.5 year, it is 81 versus 77%. So 4% benefit of OS of Delta after 1.5 year, and which has increased to 6% after 2 years. So 6% benefit after 2 years in overall survival. Still, median OS not yet reached, and 47 months is touching for placebo arm, has a ratio of 0.78 with significant p-value. So it's 22% mortality benefit shown in the overall survival arm and 29% in the EFS arm. And after 2 years, 6% more OS benefit has been shown in the group. So this way we know that each person matters in the G junction or gastric emptying constipation. So good number of patients are getting more and more benefit, and this is the hallmark of we know regarding the immunotherapy. The patient who will get the benefit, they will get the benefit for a longer time. So just to add on 10 to 20% more and more patients will get the benefit. This scheme has been applied, and somehow it has shown the improvement. More importantly, irrespective of PD-1 status. More importantly, is come the PCR. Is the patient who will get the full doses of lot with durvalumab arm 90% they have achieved the PCR versus 7%. So just want to see that touching 12% more PCR rate has been achieved. As we seen with the breast, as we seen with the other cancers, that who are the one we are getting the PCR, they are the one will convert to OS benefit. Whether the case will be there or not, that the time will tell. But as the data has shown up that the patients are getting a good amount of benefit with the addition of durvalumab. So the thing this not written in the schema, but they have taken up the things, especially the patients who have undergone RO section, which are majority of them are there. 87% of patients have get achieved the RO section who have undergone the surgery. They have seen who has progress or recur after uh, giving the Durva plus or float arm. So just want to highlight that after 1.5 year, 6% patients are getting more benefit, which has increased to 9% after 2 years. Same the case with OS benefit. That as the time progress, the percentage of benefit has been increased, or progression or recurrence has or death has got chances decreased as the time lapse. So still not beaten defense not reached, has a ratio of 0.70, 30% mortality benefit, good 40 months DFS has been seen with placebo arm, and median is still yet to reach. So all the three parameters EFS, OS and DFS, and with PCR, all with significant p-value and good hazard ratio has shown the benefit in the gastric and G-junction patients. So number two, I was telling that patients number of cycles got decreased with the maybe PS got decrease the things. So all the way around Durva, this 2 cycles means 4 doses they have achieved. After that, median number of adjuvant is total 12. What the patient can get and what they have achieved. So from 100% to decrease to 97%. After that, it has decreased to 73 or 52%. So as the time lapses, the patient tolerability get decreased, and it's a hallmark of chemotherapy. And touching, I would that 20-25% are not able to achieve the required set number of cycles, which is there written in the designed arm. So it is from 100 to 76, and after that is gone to 52. So not 52% patients are achieved have taken durvalumab the full doses, and rest are not able to take up the things either because of progression or death or some other way around the things will be there. So 50% patient can complete the full doses of lot and immunotherapy, and we can tailor the treatment with the decrease of these doses, because our Asian patients are not fit enough to tolerate full doses of lot what is there for the of other population is there. So as we know regarding the flawed AEs and what about the Durva addition, so all are well manageable things are there, 60 and 59%. So whatever addition of immunotherapy doesn't make any difference. So just I want to highlight the grade 3 and grade 4 immune mediated side effects are there. It is 7% in the Durva arm versus 4 in the placebo arm. So that thing can be seen, and we are good enough to manage these days because we are able to preclude the things that what side effects are patient we are getting by doing the TSH, LFTs, and pneumonitis other way around. We can manage the side effects. So we know with the flawed neutropenia, diarrhea, dysanemia, febrile neutropenia can be there, and all can be manageable things all way around. Regarding diarrhea, neutropenia, these all things are there, and comparable things are there in both the ways. Nothing more significant difference has been seen by the addition of durvalumab as compared with the placebo arm. So, keeping all the things in consideration, what they want to conclude that Durva will flawed significantly improve EFS versus flawed alone in resectable patients. EFS benefit was consistent across subgroups and geographic regions. No new safety concerns were identified. OS data are encouraging. Final analysis pending. And Methon supports global adoption of perioperative durvalumab plus flawed as a new standard of patient with localized gastric and G adenocarcinoma patients. With localized, it means up to 4A. So this is the trial has been published in the NEGM. So this is what they want to highlight the two three things. What did the research tell us that participants treated with immunotherapy, durvalumab, and immunotherapy in a specific combination of four medications were more likely to live longer without their cancer growing, spreading, getting worse, or recurring. Side effects were consistent what we are to manage in real world patients. How does this research impact people with susceptible this thing caregiver healthcare professional treating this way? And we want to show that treatment with durvalumab fraud could become a new standard of care in coming times. And where I can access the article which is written there is NAGM 2025 article. We can go through the things. These are the all are the sites and the countries where this trial has been included except India, and we can see it's a pan country design, and this is things I want to tell. Thanks a lot. And then that's all from my side. If something is there from the participant dot Ankit, we can love I can love to answer.
So, thank you so much, sir. I
Okay.
think it's a very important study, but considering other factors in Indian scenario, especially the cost. So, you want to change your practice Monday morning, or you still want to have a longer follow-up?
Mr. Ankit, there are two things like I will start the you have started the webinars, you have taken that this hydronophily is coming up, the immunotherapy from Intas, and I think what I've run from the company owners, they're saying that they've going the very minimized cost, just like 20-30,000 only, or just like 50,000 per cycle only. I think the time will come. We know when Pembro started up with 70 lakhs per year, this come to 10 lakhs only, and I think in coming times more and more new Chinese immunotherapy like toripalimab and this one has come up, and this can ease our genes, and we can give this thing to our patient, especially it's not for the maintenance setting. If someone can tolerate or can give for periphery setting only 4 doses of durvalumab is I think good enough to achieve the PCR and RO section, and that can in turn convert into other way around if someone not able to achieve the maintenance durva. And it's not the hallmark that we can start the practice from day one, but obviously data will show that we can start up the things from day one also. But because in any point of day, if someone is not achieved the RO section, we are giving capox plus Nivo data is there. We have to get Nivo cap. So we are good to start. And regarding the finances part, I think as what we are seeing 5 years back, in the coming 1 or 2 years, I think immunotherapy will also in the reach of most of our patients.
Yes, sir, I totally agree. And I think in current scenario, we are getting more and more IO agents from different
Yes,
countries at half
yes,
the cost of what we were getting from pembrolizumab. So I
yes,
think most of us would be even convinced to replace one IO with the other IO because the mechanism of action is uh, similar, same.
yes, yes.
So I think thank you, Dr. Deepak. It was
Okay,
a
thank
very nice presentation. Moving on to the next extract. We'll be talking about the breakwater trial, that is the analysis in the first line use of encorafenib and cetuximab along with chemotherapy in BRAF V600E mutant metastatic colorectal cancer. And for that, with us we have Dr. Preeti Agarwal. She is a senior consultant medical oncology at Narayana Multi Specialty Hospital, Jaipur. Over to you, ma'am.
Hello, good evening, everybody. So I want you to share my slides.
I think
Umang, please share ma'am slide.
So, to begin with, good evening, everybody. I thank Dr. Ankit Batra for giving me this opportunity to talk about this abstract which was presented in ASCO GI Symposium this year. So, this is a breakwater analysis where they analyzed first-line encorafenib cetuximab chemotherapy in BRAF mutant metastatic colorectal cancer. Next slide. Next slide. This was a declaration of interest by Dr. Stock. So, as we all know, the patients of BRAF mutant colorectal cancer, they do poorly. BRAF mutation is a poor risk factor in patients of colon cancer. And we know that EGFR inhibitors, they don't work in metastatic colorectal cancer who are BRAF mutant, because down the line it is a BRAF mutation and EGFR is first in the sequence, so it doesn't work. So this is the trial where they wanted to add encorafenib, which is a BRAF inhibitor, along with EGFR inhibitor cetuximab to the baseline or to the backbone of FOLFOX 6, and they compared with the standard of care arm, which is either FOLFOX or either FOLFIRI or plus minus bevacizumab. So next slide. So BRAF mutations in background, BRAF mutation occur in almost 10% patients of colorectal cancer, depending upon the site, depending upon the area. So encorafenib is a highly selective ATP competitive small molecule BRAF inhibitor, which has anti-proliferative as well as anti-apoptotic, it has apoptotic property as well. In tumor cells who express BRAF V600E mutation and has prolonged pharmacological activity compared to other BRAF inhibitors. Preclinical data has demonstrated combinational benefit of EGFR inhibitor cetuximab and encorafenib with cytotoxic chemotherapy. Encorafenib plus cetuximab is approved as a second line or later line, and as per the Beacon study, and first line chemotherapies with or without biological agents have limited efficacy in BRAF mutant at colorectal cancers. So there is no currently first line activation pathway targeted treatment for patients who are BRAF mutant positive colorectal cancer. So Breakwater is the first phase 3 study which evaluated addition of targeted therapy in previously untreated BRAF mutated colorectal cancer. Next slide. So it's an open label multi-century phase 3 study which included patients more than 16 years of age or more than 18 depending on the country. First line treatment where no prior treatment was done. The disease should be measurable, and BRAF mutation and by local or central laboratory testing, performance status either 0 or 1 with adequate marrow, hepatic, and renal functions. And the excluded patients who had prior received treatment, brain mets were excluded, MSI high patients were excluded, unless patients were ineligible for receiving checkpoint inhibitors due to pre-existing medical condition, or there is a presence of RAS mutation. These patients they excluded. They divided patients into 3 arms. Total 637 patients were randomized, and they divided patients in 3 arms. First arm received just targeted therapies, encorafenib plus cetuximab, and the second arm received chemotherapy plus encorafenib plus cetuximab, and third line, which is a standard of care, which is chemotherapy plus minus bevacizumab. There were 2 primary endpoints: progression-free survival and overall response rate, and by blinded independent central review. Secondary endpoint was overall survival. So at this ESCO, they presented overall response rate and an interim analysis of overall survival and safety in EC plus FOLFOX arm compared to standard of care arm. Sorry. Next slide. Yeah. So, how the statistical analysis, what they did was, if overall survival was significant at the alpha of 0.000.001, then only the overall survival interim analysis was done, and was all significant at a portion of 0.001. Next slide. So, summary of disposition. The median duration of treatment was 28.1 weeks in EC plus Folfoxam versus 20.4 months in standard of care arm. These are the follow-up months where the patient was continued treatment in both the arms. Next slide. So the key demographic data, the three lines were equally balanced with the median age being 60 years. There were equal amounts of male and female. Only echo PS0 and 1 were included. Almost 60% patients were right-sided colon cancer. As we know, BRAF mutation is more common in right-sided colon cancer compared to the left side. All the arms were equally balanced. Next slide. So this is the overall response rate. So the overall response rate in standard of care arm was 60%, which was increased to 60.9% when we add ECs, when they added EC to the Folfox backbone. With 2.7% patients achieved complete response, and almost 58.2 patients achieved partial response, and 28.2% patient achieved stable disease. Non-CR, non-progressive disease was seen in 2.7% patients, and 2.7% patient had progressive disease. And so the patient with duration of response more than 6 months was seen in almost 70% patients, 68.7% patient with EC plus Folfoxam compared to 30.34% patient in standard of care arm. And patient with duration of response more than 12 months was seen in almost 22.4% patient, which was doubled compared to standard of care arm, which was seen in only 11% patients. Next slide. So we can see almost all subgroups were favored. All subgroups, including age, gender, performance status, number of organs involved, right or left-sided tumor, or presence or absence of liver metastasis, all favored the use of EC plus Folfoxam. Next slide. This is an interim overall survival. We can see the 6 months overall survival. It was 87 versus 92%, while 12-month overall survival, 66% versus 79%. And so the median overall survival was not reached in EC plus Folfoxam, while in standard of care arm, it was 14.6 months. Next slide. So, treatment-related adverse event, it was seen in almost 99.6% patients compared to 97.8% patient. Grade 3-4, it was seen in 74% patients, while it was seen in 61% patients. Grade 5 adverse event and was seen in 4% patients in both the arms. So adverse event related to drug was seen in almost 98% patients in EC plus Folfoxam. Next slide. The most common adverse event being nausea. The others are anemia, diarrhea, decreased appetite, vomiting, neutropenia, asthenia, fever, neuropathy, because it may be because of oxaliplatin, rash, fatigue, arthralgia, neutropenia, alopecia, and constipation. Next slide. So dose modifications due to adverse event. Almost 11% patients had discontinuation of encorafenib and 13% patients cetuximab, and almost 22% patients had reduction in the dose of encorafenib and 6% in cetuximab, and dose interruption was seen in almost 56% patients. So yes, there were dose interruptions, there was dose discontinuation as well as dose reductions. Next slide. So conclusion. So breakwater study showed significant and clinically meaningful benefit in terms of overall response rate, and one of the dual primary endpoints in EC plus Folfoxam versus standard of care arm, that was rapid and durable. Data show trend for an overall survival improvement with EC plus Folfox versus standard of care. Follow-up is ongoing with planned additional interim and final analysis. It is well tolerable. There is no substantial increase in chemotherapy dose reduction or discontinuation because of adverse event. The most frequent adverse event were consistent with those with expected with study drugs. Pre-specified analysis of mature PFS and OS data is planned. It supports breakwater, supports EC plus 4 new standard of care in BRAF mutant colorectal cancer. Next slide. And because of that, FDA, there is an accelerated FDA approval. So this is layman summary. In patients with BRAF mutant and colorectal cancer, EC, addition of EC to chemotherapy causes tumor to shrink faster and tumor to shrink more, with improvement in overall survival. People with this type of cancer are this type of cancer with BRAF mutation and has impact in survival. So, EC plus Folfox is the new standard of care patient in patients with metastatic colorectal BRAF V600E mutant colon cancer. With this, I thank you for your patient listening, and I am open to the questions if any.
Thank you so much, ma'am. I think encorafenib is still not available in our country, but definitely in the era of precision oncology, it was a very important trial. And we know that previously all the BRAF inhibitors along with the MEK inhibitors were used in the second line. So sequencing is very important, and comparison of survivals in between the breakwater as well as the previous strategy which we use is very, very important, especially for those patients where logistics is an issue. So not only this, it is also very important when we combine the agents together. So it's a very important study, giving us more ways to treat these kind of rare cancers in future, because we all know that BRAF itself is a very poor prognostic factor, and usually the PFS in the first and second line are not that great.
Yes,
Encorafenib is
yes,
available.
completely agree. Because we know that BRAF mutant lung colon cancer, they do fairly bad. So yeah, we need some targeted therapy to add upon, and I think this is one of the good option, because we know it has worked in second line and it should work in first line.
Yes, definitely. I think even the use of dabrafenib if encorafenib is not available is justifiable till the time it is available for our patients.
Yes.
So thank you so much, ma'am. If any questions from the audience, we can take that regarding the previous two abstracts. Okay. So if none, we'll move forward. Next, we have a discussion on the update of the Checkmate 577 track. And for that, we have Dr. Jagdeep Singh, sir. He's a senior consultant medical oncology at Cancer Centers of America in Amritsar and also associated with DMCS Ludhiana. Over to you, sir.
Hi, Ankit.
Hello, sir. How are you?
Fine, fine. How are you? Congratulations for conducting this webinar. So thanks for the slides. So I'll be discussing some of the updates on this 577 trial. So, and at the last, I'll have one discussion regarding this Matterhorn and this what 577 trial is. So what the update we have for the adjuvant nivolumab in the resected esophageal or G junction cancer following the NACRT. So final analysis from this Checkmate 577 trial. Next slide. So we know that 5 years of minimum follow-up DFS and distant metastatic-free survival benefit sustained in the patient who received this adjuvant nivolumab versus placebo in patient with the resected esophageal or gastroesophageal junction following NACRT. And this median DFS continued to be doubled with this nivolumab adjuvant, that was almost close to 21.8 months versus 10.8 months. And nivolumab demonstrated a 16.4-month improvement in the median OS with a higher 5-year OS rates versus placebo, suggesting a meaningful benefit. This improvement in OS was enriched in patients with a PDL-CP score more than 1. And considering this higher rate of subsequent systemic therapy in the placebo group, ad hoc analysis accounting for the potential confounding factor of this subsequent therapy, this suggests that OS benefit with the nivolumab as compared to the placebo. And of course, this was very well tolerated and there was no new safety concern on the longer follow-up. These results, they did supported this nivolumab that can be a standard of care for patients who have been exposed to the neoadjuvant NACRT in the resected esophageal or gastroesophageal junction and who have a residual pathological disease after this neoadjuvant treatment. Next slide. So this in this trial, that is 577 Checkmate, this nivolumab demonstrated a statistically significant and clinical meaningful DFS as compared to the placebo in the adjuvant setting, with a doubling of the DFS, and it was very well tolerated, and there was no new safety profile. And based on these results, it was globally approved for the adjuvant treatment of patients with a resected esophageal cancer or gastroesophageal cancer who had a pathological residual disease following a NACRT. And this remains the only approved immunotherapy for operable these gastroesophageal junctions. And OA data are lacking in this setting. And here we represent the final OS analysis along with a longer follow-up of DFS and exploratory endpoint from this trial. Next slide. So this was the schema of the trial. We can very well see that prior to staying that stage 2 or 3 esophageal or gastroesophageal junction could be adenocarcinoma or squamous cell carcinoma. The lower esophagus patients with NACRT underwent a surgical resection, and all the patient had a R0 resection, and the patient must have a residual disease. And then those patients were randomized to either adjuvant nivolumab or placebo for 1 year. And the primary endpoint was the DFS, with the secondary endpoint was the overall survival rate, and OS at 1, 2, and 3 years, and exploratory analysis was the distance metastatic free survival and the safety. And of course, the stratification factor was based on the histology and pathological lymph node status, and the most important is the PDL1 CPS scoring. And if you can see at the data cutoff, that is in the November 2024, the median follow-up was almost 78.3 months. Next slide. So these were the baseline characteristics of the patient who were randomized with regards to nivolumab or the placebo. So you can see with respect to age, gender, race, or performance status, and the disease at initial status, or whether tumor location at the trial entry, histology, pathological tumor status, pathological lymph node status, PDL-CPS scoring, and time from clean section to and randomized. They are almost well balanced with a slight difference in both the groups. Next slide. So, if you can see the patient who were exposed to nivolumab, that is close to 532 patients, all patients were treated, and approximately 50% patient complete the treatment, and there was a lot of discontinuation. So you can see approximately close to 30% patient had a disease progression even with the nivolumab, which is significantly less as compared to the placebo, which showed that approximately 44%, and a lot of patient had an adverse event related to this nivolumab, that is close to 11%. And median duration of treatment was close to 10.8 months with the nivolumab and 9 months with the placebo. And you can see close to 44% had a disease progression, and death was seen in 56% patient of the nivolumab, and it was 62% in the placebo. And again, the progression was seen in 49%. Next, please. So coming to the DFS, you can see the median DFS was close to 21.8 months versus 10.8 months. So almost doubling of the DFS with the adjuvant nivolumab in patient post R0 resection with the residual diseases post NACRT. And this clinical meaningful improvement in the DFS with the nivolumab versus placebo was maintained even with the longer follow-up. Next slide. So coming to a DMFs, so again with the nivolumab, it's a significantly longer, that's 27.3 months versus 14.6 months with the PFS. And again, this was on longer follow, this distant metastatic free survival was even continuing. Next, please. So coming to the overall survival, you can see the median OS was 1.7 months with the nivolumab, and with the placebo it was 35.3 months. And again, you can see the hazard ratio was 0.845. So median OS was 16.4 months longer, and this 5-year OS rate was higher with the nivolumab as compared to the placebo, suggesting a clinical meaningful improvement in the OS. But again, the catch is statistical significance was not met with this a significant improvement in the numerical improvement in the OS. Next slide. So coming to the overall survival subgroup analysis, you can see, so almost all the patients, they had a benefit who received this adjuvant nivolumab, but with the coming to the PDL CPS scoring, the patient who had a score less than equal to 1, they did not do a better as compared to the patient who had a higher score. So based on this, all other factors, they favor the adjuvant nivolumab. Next, please. So coming to the OVOS by the PDL CPS scoring, you can see the patient who has scored more than 1. In those patient, median OS was 40.45 months, the nivolumab versus 33.5 months. And in the patient who had a CPS score less than 1, the patient who were in the placebo, they did a better as compared to the patient who were the adjuvant nivolumab. Next slide. So if you can see that overall survival adjusted for the subsequent therapies, again, higher percent of patients receive the subsequent systemic therapy in the placebo arm as compared to the nivolumab arm. And ad hoc analysis using two-stage method suggests the OS benefit with the nivolumab versus placebo when adjusting for the confounding facts of the subsequent treatment. So still, if you can see the patient who had received the adjuvant nivolumab, they were still doing better. Of course, this even after advance, the patient who had progressed the placebo, they received the subsequent immunotherapy as a palliative setting. Next slide. So coming to safety summary, there was no new safety concern as regard with the nivolumab, and this is even well tolerated in the patient who received the adjuvant setting. Next, please. So to summarize, after 5 years of minimum follow-up, this DFS and DMFS benefit were sustained with the adjuvant nivolumab versus placebo in patient with a resected esophageal or gastroesophageal junction following an NACRT. And this DFS was almost double what we had with the placebo. And there was a numerical increase in the OS, that is 16.4 months with the adjuvant nivolumab. But though this improvement was not significant statistically, but in the patient who had a CPS score of more than 1, this overall survival benefit was statistically significant. And considering the higher rate of subsequent systemic therapy in the placebo group and ad hoc analysis accounting for the potential confounding factor of subsequent therapy, could be this OS benefit with nivolumab and placebo can be explained. And of course, it was very well tolerated, no new safety concerns. These results support that adjuvant nivolumab as a standard of care in a patient who received NACRT following this esophageal cancer and gastrophiling and had a residual pathological disease. So I think this summarizes my talk. So just one thing I would like to ask, that initially we did not had an answer what could be the exact treatment options before the ESOPEC trial came for the esophageal, lower esophageal adenocarcinoma or gastroesophageal junctions. But this ESOPEC trial addressed the same. But now what this Matterhorn, that's a D flot versus flot, this D flot is even doing better than the flot. So I think this could be a game changer in the future. So adjuvant nivolumab, you can see it, a lot of confounding factors. That is one, the patient had received a subsequent nivolumab in the progression. So OS could not be shown a benefit over here, statistical significance. But of course, numerical difference is still there. But we need to address what we could do a patient who received a D flot as a perioperative, and what we can further modify in the residual disease. That's one question I would like to have.
Yeah, definitely, sir. I think things are changing very rapidly, and with this Matterhorn and Isopet, uh, we are shifting modes against the radiotherapy. Even the surgeons are not very pro for uh, cross protocol and then doing a surgery. So they also want peri-op things to evolve.
Maybe
And if
Ankit,
we have data to
I,
support,
I recently discussed this one. There was one debate of NACRT versus NACT, and I had a discussion debate with the Dr. Dilip Kadiwal from TMH. And I at that time I was patting for the ESOPAC. I think now it has shifted to DFLOT. And moreover, still you have a data to give in a adjuvant setting with the D continuing. So what we were addressing in the adjuvant nivolumab, that is 577 checkmate trial, that could be addressed by the durvalumab in the residual disease. That's what I thought. And maybe this DFLOT could be a better option in the adenocarcinoma specifically. If you go with the squamous cell pathology, this NACRT protocol is still a better rather than going for a NACRT.
yeah, totally agree, sir. You wanted to have some comment on the Matterhorn. Jagdeep, sir?
Is somebody asking some question I could not understand?
No, sir. You were telling initially you were telling to have some comment on the breakwater as well.
So I'm not able to understand what has been said to you.
I think some network issues, sir.
Okay. Okay, no issues. Thank you.
Okay. Thank you so much, sir. So we'll move on to the next session, that is a panel discussion on the treatment of hepatocellular carcinoma, and that is about the real world evidences for atezolizumab plus bevacizumab in hepatocellular carcinoma. So we have with us Dr. Amish Rawat, sir. He is a associate professor in medical oncology at All India Institute of Medical Sciences, Rishikesh. Dr. Shalabh Arora is a senior consultant medical oncology at Ujala Phoenix Central Hospital, Haldwani. Dr. Karan Kumar, associate professor in Department of Hepatology, Mahatma Gandhi Medical College and Hospital. And Dr. Shrikant Tiwari, senior consultant medical oncologist at Sagar Multi Specialty Hospital, Bhopal.
Dr. Ankit, I think there is some issue with your audio. You are not audible. Since last 2-3 minutes, you are not audible.
Just 1 second, sir. I'll check. Is it better now, sir?
Yes. Better now.
Okay. Please allow me to share my screen. Yeah. So I hope my screen is visible.
It's not visible.
Yes,
Yeah.
so we'll be discussing about the management of what are the practices, real world evidences, and how do will individualize their management of the hepatocellular carcinoma. So I think we all know that these are the basic BCLC and ESMO guidelines to treat these kind of patients, and what has changed over the last few years. Any patient with advanced hepatocellular carcinoma, we take a lot of factors uh, to differentiate and stratify patients, including the performance status, what are the liver function, the involvement of the disease, and what are the etiology. It is also now coming up very rapidly. So we need to see how to treat this patient who are all unresectable, and what are the systemic therapies. So these are the guidelines. This was BCLC guideline, which was last updated in 2022, and the use of immunotherapy with VEGF inhibitors or the dual IO is the current standard of care in the first line, followed by various second line treatment and third line treatments. And these are the treatment goals by the stage of hepatocellular carcinoma. What are the goals? How do we decide for the local therapy and when to use that, when to add on with the systemic therapy? What are the suitable patients and what are the recommendations? So all these factors are totally taken into consideration, and it's a multidisciplinary decision to use the local therapies or to use radiation along with the systemic therapies. And timing is also very, very important. So if we talk about BCLBB, our main goal is to shrink the tumor and cure by combination of systemic therapy and whatever local therapy we can use. And if we talk about BCLCC, so there it is important to prolong the OS by using and sequencing multiple lines of treatment and maintaining the residual liver function, which is there. So these are the phase 3 trials in the advanced hepatocellular carcinoma, and how it has evolved over the last, especially 5-6 years. And we have seen the evolution right from the SHARP trial, sorafenib, then lenvatinib, and then the advent of immunotherapy, that is IM Brave 150 use of atezolizumab, bevacizumab, which was there in 2020, and it is still holding the fort. And then various other permutation combinations of immunotherapy and TKI has chipped in. So, moving on, like there are a lot of still issues, questions which are still remain unanswered, or I would say that variability in the treatment of patient, because we see a different set of patients. So, maybe I'll ask sir first that what has been your experience in selecting first line therapy in metastatic or unresectable hepatocellular carcinoma, and how do you decide on the first line treatment? Hello, am I audible?
This question is for whom?
Dr. Amish Rawat, sir.
Yes, Dr. Ankit, you're audible.
Yes,
Am I
sir.
audible?
So, yes, sir. Yes, sir, you're audible. So, what is your experience and how do you select your first line of therapy in this metastatic or unresectable hepatocellular carcinoma, sir?
So since I am working in an academic center, so by default, most important consideration is cost consideration and feasibility of the treatment that we are planning for. So vast majority of the patients, they are actually not eligible because of financial reason for IO or IO plus TKI, IO plus VEGF inhibitors. So point is most of our patients are left with the choice of either offering lenvatinib and sorafenib. So these are the two choices by default 90%, 95% of my patients are having. So in this context, we have also compiled a data of retrospective data of last 5 years. We compiled around 177 patients, and with that permutation combination of these TKI, the survival is almost same as was reported in landmark trials in Reflect and Sharp. So if patient is having poorer performance score, higher disease burden, more than 50% liver is involved, then sorafenib is relatively better, so it works better. Relatively fitter patients, lesser disease burden, lenvatinib fares very well. We are having quite a few number of patients, those who are surviving beyond 1 year with this kind of strategy. And yeah, our patients are having more disease burden, more portal vein thrombosis, more than 50% of liver involvement is pretty common. As such, decompensated component of the liver failure, hepatocellular failure is also relatively much more in our real world setting. Then esophageal varices can also be one of the important consideration when we are planning for bevacizumab in this setting. So these kind of things that I take in consideration, whether patient is hepatitis B positivity, hepatitis C positivity, what proportion of the liver is involved, portal vein is involved or not, esophageal varices are there or not, and obviously most important consideration in financial feasibility.
Yeah, I totally agree, sir. But if financial or logistics issues are not there, what would be your choice of treatment? And suppose in a patient who had a high risk of bleeding, then in that
Yeah.
scenario, what would be your choice?
So in that case, like for example, if patient is having a high chances of esophageal varices, then as of now, I have not used any IC plus IC, but by default, I offer such patients TKI only as of today. And in rest of the setting, when there is no cost constraint and anything, atezolizumab plus biasuzumab have worked very well. Like I have treated one such kind of patient who was failing on 3-4 lines of TKI. Even in fourth line setting, this combination provided some meaningful benefit in terms of at least in quality of life.
Yes, sir, I agree. So, moving on, Dr. Shalab, would like to understand your thoughts on the patient selection criteria in most of the pivotal phase 3 trials for systemic therapy. Are you happy with that, or you have some other thought process?
So for the most part of it, I think I agree with Amit sir what he has said. Basically, leaving out the cost factor, I think I would prefer atezo-bev in patients for most of my patients. However, if patient has poor PS or there's a high risk of bleeding, patient is not willing for variceal screening or EVL. In that case, I would tend to avoid bevacizumab and probably offer Himalaya approach for such patients.
So, Dr. Karan, I would like to understand from you since you are from hepatology side. Uh,
Yeah, I'm odd man out here. So first of all, I would like to iterate one thing. HCC is primarily a disease of liver with a cirrhotic background. Patient usually don't die of HCC, they die of liver disease. So the thing is to guide a treatment, the most important thing is to understand what is the liver reserve the patient had. And by liver reserve, I mean the functional reserve, which is estimated by the CTP score, the LBI score, the bilirubin and albumin are key determinant of determining having what is the liver reserve. And second is portal hypertension, which is this varices are a surrogate marker of it. I approach HCC in a slightly different way. Normally, metastatic HCC and with the portal vein thrombosis, they are clubbed together. I keep the portal vein thrombosis and when the disease is confined to liver versus a metastatic disease. If the disease is combined to liver, I always tend to uh, add on a local regional therapy along with the immunotherapy so that if the tumor is downstage, I can offer transplant to my patient. If the disease is metastatic, then for this only the systemic therapy and that preferably atezo-bev. Uh, I understand the financial concerns are there, but since I'm working in a transplant center, almost 50 to 60% of the patient with advanced SCC, they opt for this atezolizumab thing, and they are on immunotherapy.
Okay. And as a pathologist, how do you see the transformation in the etiology from viral to a NASH? What are your thoughts on that?
It is a very significant change in the etiology burden. Earlier, it was used to be viral. Very recently, we published our real world paper of 160 HCC from 6 centers, in which 56% of the patients were having etiology as NASH, 18% were Hep B, and 16% were Hep C. So even Hep B and Hep C combined, they form 34%. NASH alone is almost 56% of the tumor burden is contributed by NASH only.
And do you think any change in the treatment in the two groups is there, or you can treat it the
See,
same way as we are treating with the viral ones?
I'm very now there are a lot of data coming up that NASH there is extra T regulator cell in the NASH tumor. Tumor is not cold. This tumor is cold. They don't perform well with immunotherapies, so and so. Basically, when a trial is designed, if you go by the IMBRAVE one or the Himalaya one, they are powered the randomization and the study design when the etiology is not taken into consideration. If you do a post hoc analysis in such a study, the difference if you get it is not meaningful to my understanding. And secondly, if in real world, I will say the 160 patients I'm talking about, in which there were 56% of the patients were NASH, the response rate was almost similar in the NASH group as well as the non-NASH or the viral group. The only prognostic factor which we found was instead of etiology as NASH, those patients who have a type 2 diabetes, those who are having a CRP level more than 100, they respond poorer with immunotherapy as compared to those who were non-diabetic and were having a lesser CRP.
So I think it's too early to say whether the treatment differences or the response differences will be there and the outcomes will be there, unless and until we have newer trials taking these factors into stratification and analyzing them with a powered study. So, Dr. Srikanth, just wanted to understand that uh, do you see similar kind of patients what we read in the trial world, and are they same in the real world, or you see that more of advanced more child B and C cases as compared to what we see in the uh, trials? What is your experience and
Definitely, in our part, we are looking more patients who are in BCLC, BSC, and with childhood B and C. We also used to see childhood, at least childhood B, we used to see most commonly, because many a time the patients used to take more time to reach to medical oncologist and confine more towards the gastroenterologist. This is the one part. The second part, I just wanted to see all other our co-panelists has enumerated the different parameters on the basis of which we select the first line therapy. I would like to add one thing. We should also consider the liver function reserve, because we have now the second line option and third line options. Maybe in future fourth line, fifth line options will also be available. So if we have to also maintain the liver reserve, so that we can put patient on the second line, third line treatment. So that is also an important part when we are selecting the first line therapy. We should keep in mind.
yeah, thank you. So this was about the IMBRAVE 150. We know though that it's a very pivotal, important trial, and it was included the unresectable SCC with no prior systemic therapy, and BCLB or C were ineligible for local therapy, along with child pug score A, class A, and good performance status. So they were randomized 2:1 into atezolizumab versus sorafenib. And you can see that the primary endpoint, that is overall survival, had a hazard ratio of 0.66, although their long-term follow-up is not there. And it would be better if we can have that. And then similarly, PFS benefit close to 2.5 months was there. And overall response rate, if you see, were 3 times what we have seen with the sorafenib. with almost 8% CRs with the atezo-bev combination, whereas less than 1% with the sorafenib, and the VCR rates were also very well improved. So we know that immunotherapy is approved for SCCs and most of the cancers in today's world, and it is going to increase. The number of trials are going to increase. The number of options are going to increase. So how do you interpret the OS data given that we do not have head-to-head comparisons, especially in terms of KM curve separations or hazard ratios and risk reduction and response rates? So that's almost a challenge for a clinician in most of the settings. And although it's the head-on comparison will never be there, but and we are continuing our practice with cross-trial comparison, which is not the right way to do. So, Dr. Amit, sir, what's your view and how do you take these questions? Are they relevant to you, or you just strictly stick to the individual trials? Amit Sarawat, sir?
Yes. So in classical oncology, we as such we don't compare like we don't go for cross trial comparison because the type of recruitment strategy, type of treatment setting was totally different. But practically everyone is doing that. So it's not like that. That is strictly contraindicated as such. So yes, we do look at what were the KM curves in both the reference studies and what was exactly the statistical consideration, how strong that evidence was, how wide the confidence interval were for that matter. For example, that last presentation that checkmate 577, that hazard ratio was crossing 1. That was 1.04. So although that was reported to be a clinically meaningful report and everything, but at the end of the day, by statistically, that is not significant. So yeah, that is important whenever we are taking into consideration of this trial report, what was exactly the shape of the curve, what was actual hazard ratio, and what was the confidence interval of such reported hazard. Durable response, yes, obviously, that is one of the important considerations, especially when we are dealing with such a devastating disease, when we don't expect survival of more than, say, 10 to 12 months with standard line chemotherapy, standard line TKI therapy as such. So duration of response, yes, is an important consideration, especially when we are expecting very limited survival.
Yes, sir, I agree. And I think that is the most important thing what we have seen with the immunotherapy, that long durable responses are there. And yes, I agree with you that for academic purpose, I think we should interpret and critical analysis of all the trials should be done the way we are doing. But for the benefit of the patient, I think practically everything is the cross trial comparison is also giving the benefits to the patient. So we have seen that prioritized requirement for the first line systemic therapy in this setting is there. And if we see this publication, so if we see there are a lot of wide benefits in terms of high response and low progressive disease rates and long PFS and OS, whereas these kind of therapies as compared to the conventional TKI are having less grade 3 and grade 4 side effects and better preservation of the liver functions, and then subsequent therapies are also being tolerated or the patient reaches to the subsequent line of therapy to the patient. So in terms of treatment selection, our gold standard is always overall survival, but because the type of patient, the scenarios which we are seeing is very important to select, and we not only every time wait for a overall survival. If you see in this, if a KM curve separates at initial 1 to 2 months, then we have a durable and a better responses. Whereas if the KM curves are crossing or before that separates at 12 months and then crossing, then also we can see that the therapy which is in which it is later on crossing is giving a better survival curve. So it is not just the initial separation. We need to have a long-term approach, and similarly seen with the other selections also. So we have various combinations, atezolizumab in combinations with bevacizumab for the management of this hepatocellular in the first line. We have a systemic literature review and the meta-analysis, and we can see that various permutation and combinations of TKI and immunotherapies are there. And if you see there, this we can see that majority of the trials have a hazard ratio for overall survival in the tunes of 0.6 and 0.7, and the probability of uh, atezolizumab with bevacizumab is slightly superior as compared to the other combinations and permutations. So this was about the IMBrave 150 and the responder analysis. So they have analyzed the responders on the basis of how they have responded, like they have clubbed the complete response and the partial response together, then the stable ones separate and the progressive ones differently. And they have seen that at 4 months and 6 months, those who have responded initially are doing very good. So a patient selection and the way they respond is also very, very important in terms of continuation. So it's very difficult to say right at the upfront who will going to respond or not and whether to select immunotherapy or not. So these are the waterfall curves of the atezobev as compared to sorafenib, and the tumor shrinkage is close to 74% in the atezobev arm as compared to 54% in the sorafenib. Then the durability of response, as told, is very, very important in oncology because we have a lot of chemotherapies, not in SCC, but in other settings than TKI here. So initial response in most of the settings is very good, but the durability is not there. And that's the thing which we are lacking. So IO has given us one of that option that those who are responding are, there is a tail or curve of that and they are responding for long. So we have uh, these three different factors which helps us to in terms of tumor response for long-term survival, the high response rate, the deeper response, and the long. So these all these factors what we want in most of our tumors, the atezobev in this trial has satisfied most of the factors, and in future we need to see the permutation combinations of the other trial. So with this, Dr. Shalab, I want to have your opinion that how comfortable or how easily you are selecting patients for bevacizumab in patients with varices, and how do you take that? What is your experience? What is your thought process for that?
So I think for patients who have untreated varices, I would, definitely consider the possibility of atezo-bev, but I am very skeptical with the bevacizumab part of it. And if at all I do use this combination, I would use a lower dose of bevacizumab than was used in the trial.
And have you tried like starting with the atezo and giving a conservative treatment for the liver, and once in a few weeks time the liver responded better and it is the liver function is resolved, and then you can add Bevacizumab? Have you tried that, and or anyone else doing that?
So far I haven't, but yeah, I think the way you're mentioning it definitely sounds like a reasonable approach. But generally what I do, I would start the patient not on 15 mg per kg, but rather 7.5 or 10 mg per kg. I know that's suboptimal dosing. I'm digressing from the trial plan, but wherever I have reservations about the bleed part, go to this. Maybe
No,
the
I totally agree that.
hepatologist, yeah, maybe the hepatologist can better tell how real that risk of bleed is.
Yes, that's what I want to reiterate. Why everybody is so afraid of variceal bleed with the atezolizumab? Atezolizumab don't causes bleed. First of all, the bleed is caused by portal hypertension, tumor which is present in the portal vein that increases the portal pressure, that causes bleed. When you the problem with bevacizumab is it can hamper with healing or the spontaneous stoppage of bleed. It per se is not bleed causing drug. It, it hampers with stoppage of bleed. And real world experience, if you will ask me, the reported did a meta-analysis of 5,400 patients, 48 studies. Real world, the bleeds is seen in almost 2 to 3% of the patient, not more than that, with atezolizumab also. So fear of bleed is a bit high reported than what is actually seen. If you ask me, the bleed is because of portal vein thrombosis, tumor invading the portal vein. If you treat the tumor, portal vein gets cleared up, the risk of bleeding will decrease, not increase. Secondly, regarding the management of the varices part, the varices are graded in three parts: grade 1, grade 2, grade 3. Grade 1 and grade 2 are the small varices. They can be easily managed with beta blocker carvedilol. They will decrease the portal pressure and will decrease the risk of bleed. If the varices are grade 3, we can band them, do a EVL, endoscopic variceal ligation, wait for 2 weeks, then we can easily start with immunotherapies. bleeding risk in this Imbrave also, it was almost similar in sorafenib as well as this atezolizumab. The main reason is they have included almost 40 to 45% of the patient who had this portal vein invasion, means they have got higher portal pressure. So bleed per se is related to disease and portal vein invasion and portal pressure rather than the drug per se. And approach regarding
Yes,
the
so
approach,
I think Dr. Karan is quite right that per se BEV might not so much contribute to the bleed,
yes.
but we all have that one patient who has given us nightmares, who has come with the bleeding, and you tend to remember that one patient. And
Yes. No, you are right, Dr. Shalab. Actually, matlab, what I want to reiterate is the patient who you have encountered must be having main portal vein thrombosis. The patient who have got a portal vein invasion, now they have got a very high portal pressure. Even if you treat them or you don't treat them, they are at a very high risk of bleed. And that bleed, because of the high portal pressure, it is very difficult to manage. Vivasi, just add to that because of this anti-VEGF property, it will further delays healing, and with if the bleeding happens, it will the stopping the bleed will become slightly more difficult if the patient is on anti-VEGF.
yeah, I think the point is very well taken, and it's totally unfair to reject 90% of your patients with a risk of bleeding with just 2 or 3%. So,
Yeah.
just one more clarification, Dr. Karan, that if a
Yes.
patient had undergone a EVL, after how
Yes.
many days you feel that it's safe to start back?
There's no clear guideline-wise thing. I personally use a practice of 2 weeks. Normally, the band we apply, they cause ulceration, and that ulceration heals by 2 to 3 weeks. So once the ulceration is healed, after 2 to 3 weeks, we can go with this immunotherapy.
Okay.
And just to add on, this real world thing,
Yes,
now
please go ahead.
just Himalaya people, they have last month in Journal of Hepatology, they have published a very good paper, long-term follow-up of the patient who were on STRIDE protocol. And I was surprised to see 5 months survival of 20% in patient who were given STRIDE Tremeli Durva. And another important observation was those patients who have got a 25% tumor burden reduction. This at Isobev, they have shown that 46% tumor burden reduction. In their trial, those patients who have got a 25% tumor reduction, 5-year survival rate was 49.6%, almost 50% of the patient. If they achieve a tumor burden reduction of 20%, they were living at 5 years, which is surprising with respect to HCC. 5-year survival rate of 50% or even 20% is too good to believe. So I think when this Atizobay people will come up there with the long-term data, the result will be astonishing.
Yes, even I was waiting that because it's one of the pioneer trials, so they have still not released the long-term data. And even what we are in continuation to, there is data from MyMbrave 150 itself that 26% of the patient in each treatment have had varices at the baseline, and they
Yes.
were treated. And if you see the efficacy outcomes in terms of median OS, so it was significantly better in the patients with varices as compared to those without varices. So you can see the numbers. The hazard ratio was 0.72 without varices and 0.55 with varices. Even the median PFS was also better, and overall responses rate were also better. So I think with a long-term follow-up, there is no point which should stop us, especially for the varices. Plus, this size of the varices also makes a difference when we have multiple and large varices as compared to like the grading of the varices. So the grade 1 versus the grade 3 or 4. So that also makes a difference.
Yes, the large varix, basically when we see the varix, we see from the perspective of size. Grade 1, 2, and 3 are on the basis of size, less than 5 millimeter, 5 millimeter, more than 5 millimeter. And second thing we have to see is the red color sign. If there is any red veil marking or cherry red spot over the varix, if there is any red color sign, or if this the varix is of grade 3, then they are at a high risk of bleed. In those cases, it is preemptive to use a banding before starting immunotherapy. Lesser grade varix, grade 1 or 2, or varix without any red color sign, we can easily get away with beta blockers.
Okay. So, seeing the data, the majority of the bleeding events, even in this IMBRAVE 150 ITT, were unrelated to the varices. If you see that epistaxis was the most common bleeding event, which was close to 10%, and the majority of bleeding events were grade 1 and grade 2. So if you see in the sorafenib arm, all grade bleeding was 17% as compared to 25% in the atezolizumab, and grade 3 and grade 4 were similar, 6.4% versus 5.8. So I think we should come over this fear of bleeding and should actually give the benefit of atezolizumab to most of our patients. So
Sir,
I
sorry for
think this question,
intervene, sir. Sir, sorry for
yes, please.
intervene. We are running short of time, sir.
Okay, okay. I think this question regarding
Please
the
continue.
etiology we have already discussed, and Dr. Karan has very well answered and cleared about that. So there is no clear pattern of C18 viral and non-viral etiology. Although with the cosmic trial and the Himalaya, they have shown that the benefit of the treatment in the viral etiology favors more towards the control as compared to the immunotherapy. But still, we do not have any major data, and we need to have more head-to-head comparison or stratification on these factors in further trials before we conclude on this. So there is no clear-cut pattern across these endpoints, and this analysis are only hypothesis generating. And for Limbrick 150, the efficacy of atezolizumab were seen across this etiology in terms of non-viral versus hepatitis B versus hepatitis C, and that was quite similar in all the three. So as of now, the treatment is going to be same, and there is no difference also in overall survival between the MFLD versus the viral etiologies in the post-hoc analysis of the IM Brave as well. So I think the answer to this is we need more data and head-to-head analysis or stratification on the basis of these factors. And in the systemic review and meta-analysis also, there was no significant difference in the overall survival in non-viral versus viral etiology. So last thing is that how has been your real world experience with atezolizumab and bevacizumab? I think just 10-second answers from all the panelists. We'll start with Amit Sharawat sir. What are your experiences with atezolizumab and Amit sir? Dr. Shalak, can you take that?
Yeah.
Dr. Shrikant, am I audible?
Yes, you are audible.
So, Dr. Shrikant, what is your real world experience with the atezo plus bev in your practice?
I am using it, Tizo plus Bev in unresectable HCC patients. The only thing is that we should have rigorous this endoscopic surveillance, even though the patient is having the early grade varices. But you should during the treatment we should have incorporate our this gastroenterologist along with us, so that regular this endoscopic surveillance should be done. Second thing, I just wanted to say that this bevacizumab related to bleeding is not dose dependent. If I am remembering correctly, it is not dose dependent. So even if we reduce the dose of bevacizumab in atezolizumab, if you have not followed up with and prophylaxis has not been given to the for varices, the risk of bleeding will be high. That's what
Yeah, I think these both are independent. But generally, in general, most of our Indian patients do not tolerate that much dose, that is 15 mg per kg. In my practice also, very rarely I am able to go above 10 mg per kg body weight. So I think so this was a AB real study, which was the first global observation registry, and they have been taken from various countries. And the primary objective was to describe the uptake of atezolizumab in multinational registries and what are their takes. So these were the baseline characteristics in most of them, and I think close to 34% patients had a very high AFP with BCLC3 close to two-third, and Child-Pug 5 and 6 were 60 and 35% respectively. So this was the efficacy summary in the real world study of the atezolizumab, and it was the median OS was close to 16 months with a median PFS of 7 months. So it was what we have seen in the trial world setting, and this was a real world study from the Taiwan, a long term outcome of the survival. And similarly, at 3 years, the OS rate was 31%. And if we see by the response to treatment, so in good responders, that is CR and PR, they are doing very well as what we have seen in the I am Brave 150 trial. So these results in the real world have replicated same. And at 60 months, the OS was close to 20%. So just the last question, Dr. Karan can take. And how has been your real world experience with the VP4 patients? What's your take on that, and what's your experience?
VP4 are the most difficult one to. VP4 means the tumor thrombosis invading the main portal vein. VP1 is the tertiary order branch. VP2 is if the branch of the left or the right portal vein. VP3 is if the left or right portal vein, and VP4 is the main portal vein. If the tumor is extending up to main portal vein or even beyond splenic vein or SMV, they are the worst patient to respond. And they are the patient who do have a large varus, they do have tendency to bleed. So till they,
Yeah, I agree. And the point to highlight here is that even in the VP4 subgroup, Atezolizumab has done better as compared to the Sorafenib. We know that non-VP4 are doing better, but even in this subgroup, they are doing better with the with the Atezolizumab combination. So this was the exploratory analysis of association between web skip doses or delayed, and to reassure us, to give us the confidence, it is said that even if the web dose is skipped, the outcomes are more or less equal in terms of overall survival and progression-free survival. So even if with any of the reasons, if any of the web dose is skipped, we need not worry and continue whatever planned ahead. So these are the factors which helps us to decide on the quality of life, the liver function, the overall treatment availability, and then the prognosis, and then the subsequent therapy rates in the atezolizumab era. So if the liver function is very well preserved and atezolizumab provides high rates of subsequent treatment, more than 70% of the patients post these studies were eligible for second line treatment. And with this, it emphasized that yes, the first line treatment with atezolizumab is the right way to move forward. We have similar results from the Japan and the Korean group that shown that 66 to 88% patients have received subsequent line of therapy, because there is always a fear that if we are not giving the best treatment in the first line and that is hampering the liver function, our patient is not going to reach to the second or the third line. So with this, I think the atezolizumab combination has given us the overall survival prolongation benefits regardless to the etiology and VP4 status, and a good direct anti-tumor effects in terms of PFS and overall response rate, and a manageable good side effect profile with the preservation of quality of life and the liver function for subsequent therapy. So thank you all for participating in this panel discussion and giving your valuable insights. I once again thank everyone for being a part of this panel.
you. Thank you, Dr. Ankit.
Yeah, thank you, Karan, sir, for joining.
Thank you.
So after completing this GI cancer session, we'll now move forward to the GU updates. And we have our first session, which is a sponsored session by BMS. Do we have Dr. Samit with us?
Yeah, hi, I'm there.
Hi, sir. So, moving forward, our next talk will be on improving survival and quality. MIBC, that is muscle invasive bladder cancer. So that session is sponsored by AstraZeneca. And recently we have seen a lot of updates and changes in the paradigm shift in the management of MIBC. So to discuss about that, we have with us Dr. Vidit Kapoor. He's an assistant professor in Department of Hematology and Medical Oncology at Amrita Hospital, Faridabad. So over to you, Dr. Vidit.
Thank you so much, sir. Is my slide visible?
Yeah, it's visible.
All right, thank you so much. And yes, good evening, everyone. And first up, I would like to thank Dr. Ankit sir and the organizers for giving me this opportunity. Let me just pull up the pointer. So yeah, the topic of my presentation is the management of muscle invasive bladder cancer and discussing the latest guidelines, especially regarding immune checkpoint blockade. So this is an outline of my presentation. I will briefly discuss epidemiology and staging and then move on to the management, where I will discuss certain pertinent clinical trials for chemotherapy and immune checkpoint blockade therapy, eventually ending with a few slides on bladder preservation and ctDNA. So even though even though bladder cancer is not one of the more common cancer types that we tend to see in our clinic, it is still one of the leading causes of cancer-related deaths. And if we have a look at the 5-year survival rates, then the 5-year survival rate for localized disease is around 70%, and that for regional nodal disease is around 40%. My presentation today will focus mostly on muscle invasive bladder cancer, so clinical stage T2 and beyond, including nodal disease. So having discussed epidemiology and staging, I will now move on to management. The management of muscle invasive bladder cancer has typically involved a radical cystectomy, which is the gold standard surgical intervention that includes a bilateral pelvic lymph node dissection as well as a urinary diversion. And we also know that neoadjuvant cisplatin-based chemotherapy has also been incorporated into standard guidelines, given the OS benefit of around 5 to 7%. So the role of neoadjuvant chemotherapy was established by the SWOG intergroup trial that established the role of cisplatin-based neoadjuvant chemotherapy. The regimen that was incorporated in the study was MVAC. And there are quite a few regimens that have been utilized in the neoadjuvant setting, all of them including cisplatin. Carboplatin has no role in the neoadjuvant setting. Some of the common regimens have included gemcitabine cisplatin, dose-dense MVAC, and the more traditional MVAC, which is now mostly a historical regimen. We know that gemcitabine cisplatin is an equally efficacious and less toxic regimen as compared to MVAC that has been demonstrated in multiple studies due to the high risk of neutropenic fever and mucositis with the MVAC regimen. More recently, the VESPER trial has tried to compare the efficacy and toxicity profile of gemcitabine cisplatin as compared to dose-dense MVAC, where we are utilizing pegfilgrastim to minimize some of the toxicities of the traditional MVAC regimen. And even though there is a statistically significant progression-free survival benefit with dose-dense MVAC, there has not yet been a definitive significant OS benefit with a dose-dense MVAC regimen over gemcitabine cisplatin. In my practice, I do tend to use dose-dense MVAC, especially in those patients who are young and fit, have minimal comorbidities, and for those patients who I'm trying to get to radical cystectomy as soon as possible. Since the dose-dense MVAC regimen, all 4 doses of neoadjuvant therapy are completed within 2 months. So these patients can easily be treated with definitive surgery in a shorter period of time as compared to gemcitabine cisplatin that takes around 3.5 to 4 months. But if I do have any slightest concerns regarding toxicity profile, then I do tend to lean on gemcitabine cisplatin. So having discussed about neoadjuvant therapy, there are certain proportion of patients who will benefit from adjuvant chemotherapy as well. Even though the data for adjuvant chemotherapy is not as robust as for neoadjuvant chemotherapy. But adjuvant chemotherapy has that added advantage of tailoring cisplatin-based chemotherapy that is tailored to the accurate surgical pathological staging. There are certain proportion of patients who at the time of initial cystectomy are considered to be cisplatin ineligible because of complications like renal failure, because of hydronephrosis and tumor compression. And sometimes these patients can become cisplatin eligible after radical cystectomy. So that is one case where you can utilize again cisplatin based adjuvant chemotherapy. And for patients who for some reason have not been treated with neoadjuvant cisplatin based chemotherapy, NCCN guidelines continue to advocate for cisplatin based adjuvant chemotherapy. So now that we've discussed the traditional chemotherapy regimens, I would now like to move our focus in the neoadjuvant or in the immune checkpoint blockade therapy. I will cover some trials that are pertinent in the adjuvant and the perioperative setting. So the rationale for the use of immune checkpoint blockade therapy in urothelial carcinoma comes from the fact that urothelial carcinoma is a highly mutagenic cancer. And here we can see that there are a number of mutations that take part in the tumor evolution of urothelial carcinoma, including TP53 mutation, CDKN1A, CDKN2A, RB1, FGFR3 mutations. And this high tumor burden makes the tumor environment much more easy for immunotherapy to work. And there have been several phase 2 trials incorporating and demonstrating the use of single agent immunotherapy agents in advanced urothelial carcinoma as well as in the neoadjuvant setting. So the data for adjuvant immunotherapy for muscle invasive bladder cancer comes from 3 pivotal trials. And all of them, including the Checkmate 274, the Ambassador trial, and the IMvigor 010 trial, all these trials have included a patient population that have been considered to be high risk muscle invasive bladder cancer. So all patients who have received neoadjuvant cisplatin-based chemotherapy have undergone a radical cystectomy, and at the time of cystectomy have been found to have significant residual disease, including node-positive disease, or those patients who have for some reason not received neoadjuvant cisplatin-based chemotherapy and have a high clinical T stage, high pathological T stage as well, or a high nodal stage at the time of cystectomy. Also, these patients are not eligible or have refused adjuvant cisplatin-based chemotherapy. So these patients were randomized into each of these 3 trials into adjuvant immunotherapy that included nivolumab for 1 year in the Checkmate 274 trial, pembrolizumab for 1 year in the Ambassador trial, and adjuvant atezolizumab for 1 year in the IMvigor 010 trial. And the comparator arm for all these trials was observation or standard surveillance. Of these, the most valid trial is the Checkmate 274 trial, where there has been a statistically significant disease-free survival benefit with the addition of adjuvant nivolumab for 1 year. And recent data also suggests that there is a numerical OS advantage, even though the overall survival data is still immature at this point. As far as the Ambassador trial is concerned, that is still a positive trial with a statistically significant disease-free survival benefit with adjuvant pembrolizumab. And then OS data is still not mature. The IMvigor 010 trial that incorporated adjuvant atezolizumab in high-risk muscle invasive bladder cancer in the adjuvant setting was a negative trial because there was no disease-free survival benefit that was seen. However, this trial also holds value today because of the incorporation of CT-guided DNA guided adjuvant therapy. So this is just the outline of the Checkmate 274 trial that I've discussed. Again, it was a positive trial with benefit of adjuvant nivolumab as far as a disease-free survival is concerned. The same goes for adjuvant pembrolizumab in the Ambassador trial, and then the IMvigor trial, which did not show any benefit in disease-free survival. So having covered all these trials, still even with the advent and use of neoadjuvant chemotherapy, radical cystectomy, and adjuvant immune checkpoint blockade, there is still only a modest survival benefit of around 5 to 8%. and as many as 50% patients do experience recurrence or progression following radical cystectomy within 5 years. So there still is a highly unmet need as far as the treatment goes for muscle invasive bladder cancer. So now I will discuss the perioperative immune checkpoint blockade therapy that was discussed in the Niagara trial. The Niagara trial was a randomized phase 3 trial of neoadjuvant durvalumab plus chemotherapy, followed by radical cystectomy and adjuvant durvalumab in muscle invasive bladder cancer. So here we can see the study design. The study enrolled muscle invasive bladder cancer across all clinical T stages. A small proportion of these patients also were node positive. And these patients were randomized to either receiving neoadjuvant 4 cycles of neoadjuvant durvalumab plus gemcitabine and cisplatin as compared to chemotherapy, gemcitabine, cisplatin alone. And then after 4 cycles of neoadjuvant therapy, all of these patients underwent a radical cystectomy. Following that, in the durvalumab arm, the patients were subjected to 8 cycles of monthly durvalumab therapy, and no treatment was given in the chemotherapy arm post cystectomy. The primary endpoints were event-free survival and pathological complete rates. OS was a key secondary endpoint. One of the interesting enrollment criteria was that patients who historically or by many physicians, depending on where you practice and depending on your clinical expertise, were considered to be cisplatin ineligible. So those patients who have a borderline creatinine function of between 40 and 60 ml per minute, this patient population was also enrolled. As many as 20% patients belong to this category of enrollment. And in this patient population, instead of using the standard 3 weekly cisplatin dosing at 70 mg per meter square, these patients were given a split dose cisplatin at 35 mg per meter square on day 1 and day 8 along with gemcitabine. So again, borderline renal dysfunction patients were also included in the trial. Even though the majority of patients were node negative, there were around 5 to 6% patients who had node positive disease as well. So here we have the results of the Niagara regimen. Event-free survival and overall survival were statistically improved, significantly improved. And here we can see the OS, delta OS is around 7% for the durvalumab arm as compared to the chemotherapy alone arm. And one important result that was presented recently was that the event-free survival was improved irrespective of the pathological CR rates. This also indicates to the benefit of the adjuvant component of the perioperative durvalumab gemcitabine cisplatin arm. Coming to the pathological complete response rates in the initial analysis, the results were statistically insignificant for durvalumab as compared to the comparator arm. But in a reanalysis, it was seen that there was a nominal statistical significance as far as the PCR was concerned in the durvalumab arm as compared to the chemotherapy alone arm. Now, there have been certain debates regarding the fact that the PCR rates in the durvalumab arm has been around 37%, which is slightly inferior to some of the other ongoing neoadjuvant immune checkpoint blockade therapies in muscle invasive bladder cancers that have been done in the US and in China. But the explanation for that is many of these patients had refused cystectomy. As many as 6% patients after having received neoadjuvant protocol of the Niagara regimen had refused cystectomy. So those patients were also included in the PCR analysis. And here, if we look at the post hoc analysis where patients who had undergone a radical cystectomy, the PCR rates had significantly gone up in the durvalumab arm to as high as 42%. Again, a benefit also was seen in the patient population who may or may not have been considered to be cisplatin eligible. So expanding the benefit of these patients in the borderline renal dysfunction category as well. And if you look at the forest plot, again, benefit was seen across all disease types, irrespective of the PDL1 score, irrespective of the creatinine, irrespective of the T2 stage, and also some of the patients that were enrolled with N1 disease also had some benefit. So thankfully, there were no safety concerns. Whatever adverse events were observed have been traditionally been seen with almost all of the immunotherapy trials across tumor types. And importantly, perioperative durvalumab exposure did not compromise the ability of patients to undergo a cystectomy. Uh, in fact, in the durvalumab arm, I think there were numerically a higher percentage of patients who were able to eventually get cystectomy. As high as 88% patients got a cystectomy as compared to the chemotherapy arm, where around 82-83% patients eventually had a cystectomy. The most common reason for not having had a cystectomy was actually patient preference. So to summarize the NIAGARA regimen, the NIAGARA regimen has demonstrated a statistically significant and clinically meaningful improvement in the event-free survival, which was the primary endpoint, and also the secondary endpoint of overall survival. It has improved PCR rates, reduced the risk of recurrence and death, and has shown DFS benefit across multiple subgroups. And the benefit has also extended to patients who have a borderline renal function. So again, after having read the NIAGARA regimen, in my opinion, I think all patients who have muscle invasive bladder cancer, who are eligible for a radical cystectomy, even those patients who have a borderline renal function, I think the NIAGARA regimen with the perioperative durvalumab chemotherapy regimen is the standard of care for all these patients. And this has also been incorporated now in the NCCN guidelines as a category 1 recommendation. Now, there has not been any comparative effectiveness between the perioperative durvalumab regimen compared to the CheckMate 274 regimen that included adjuvant nivolumab post neoadjuvant therapy in high-risk bladder cancer patients. But given the fact that there is an OS advantage in the NIAGARA regimen and OS data is not mature for the CheckMate 274 trial, I think the NIAGARA regimen perioperatively should take preference over the CheckMate 274 trial. So that is a summary of these trials. There is a small subset of patients who are considered ineligible for cystectomy because of their comorbidities or because of other reasons, including patient preference. And for those patients, there is a trimodality therapy or concurrent chemoradiation that can be incorporated into the care. Uh, uh, if they are eligible for such a therapy, if there are no contraindications, for example, multifocal disease or significant hydronephrosis or ureteric involvement. For such patients, I think bladder preservation with concurrent chemoradiation can be attempted. The data comes from this large 10-year study that showed that incorporation of chemotherapy in this trial was 5-FU and mitomycin that significantly prolonged loco-regional disease-free survival. But again, OS benefit was not there, even though this trial was not powered for OS. So this is where.
Sorry for intervening. Need to conclude, please, sir, as we are running short of time.
Okay. So I'll just quickly do I have 1 minute or no?
Yes, sir. Yes, sir.
Okay. So I just have to discuss the ctDNA aspect. So
Dr. Vidit,
ctDNA.
we
Yes.
have a further abstract for the ctDNA part, so I think we
Okay.
can
So
take it.
I'll just
Sorry.
I'll just conclude then. No problem. Thank you, sir. Thank you.
So I think thank you so much for such a lucid talk. And we have seen data from the adjuvant as well as the peri-op setting. So I totally agree with you that I think peri-op use of immunotherapy is doing much better in terms of outcome as compared to the adjuvant. And I think that is the way forward to go. So thank you once again.
Thank you so much.
So moving on, we have discussed about RCC, then muscle invasive bladder cancer. Moving on to the third organ of the genital urinary part, that is prostate. We'll be discussing about the role of apalutamide in metastatic castrate-sensitive prostate cancer management. And for that, we have Dr. Trivikram Rao with us. He is a senior consultant in medical oncology at American Oncology Institute, Hisar, Haryana. Over to you, sir.
Thank you, Dr. Batra and the organizing team for providing me this opportunity today. So I'm just quickly sharing my screen. So is my screen visible?
Not
Yeah,
yet.
is my screen visible? I'm audible?
Now it's visible. Yes.
Yes, sir.
Yes,
Yes,
yes.
sir. Yes.
Okay, okay. So quickly, today my topic is the role of apalutamide in metastatic castration-sensitive prostate cancer management. So briefly, according to Glopagon data, prostate is the 12th most common cancer with incidence of around 34,540 and a 5-year prevalence of around 67,000. And among males is the sixth most common cancer and is expected to increase in coming years. So the prostate cancer diagnosis may occur at various stages of the disease and progress through different pathways. So like starting from the localized to advanced prostate cancer. So to hormone sensitive and metastatic CRPC. So we have different stages. So we'll see like where apalutamide sits as per the clinical evidences available with us. So moving on to Titan trial, which is a phase 3 trial of apalutamide versus placebo in patients with metastatic castration-sensitive prostate cancer receiving ADT. So it's an international randomized double-blind placebo-controlled phase 3 trial. In this, patients with metastatic castration-sensitive prostate cancer were included with echo performance score of 0 or 1. The prior ADT of less than 6 months was allowed for castration-sensitive prostate cancer and less than 3 years for local disease. And patients were randomized to apalutamide 240 milligram once daily along with ADT versus placebo plus ADT. And they were followed until progression. The primary endpoint being overall survival and radiographic PFS, and the secondary endpoint being time to pain progression, time to SRE, time to chronic opioid use, cytotoxic chemo, and the exploratory endpoints including time to PSA progression and PFS2. So these are the baseline characteristics, more or less well balanced. The median age being 68 to 9. A majority were having echo performance score of PS1 around 63 versus 66, and majority were having Gleason score of more than 8, around 67 versus 68. And again, majority were metastatic, having M1 disease, 78 versus 84. And again, majority were having high disease volume, 62 versus 64. And around 10% had a prior docetaxel exposure. And around 15 to 18% received prior treatment for localized prostate cancer. And majority were having pain score of 0 to 3, none to mild. And the median baseline PSA is around 5.97 versus 4.02. So this is a radiographic PFS. So we can see the median PFS is not evaluable versus 22.1. And at 2-year cutoff, it is 68 versus 48%. So apalutamide plus ADT was associated with significantly longer radiographic PFS compared to ADT alone. So these are the subgroup analysis. You can see more or less all the subgroup respect to the performance score, geographic area, bony mets at baseline, visceral disease, prior docetaxel use, age criteria, disease volume criteria, and metastatic. More or less, it's benefiting in all the subgroups with a good hazard ratio of around less than 0.5. Sometimes it's 0.36 in case of low disease volume. So except the visceral disease crossing the one here, it's almost favoring all the subgroups here. And the benefit is consistent across the subgroups. So this is the final OS analysis. On the left side, we can see the median OS in the intention to treat population. We have median OS of not reached versus 52.2 months with a hazard ratio of 0.65 with a significant p-value, that is 35% reduction in risk of death. And in those, when patients were allowed to cross over from placebo to apalutamide, the hazard ratio is 0.52, that is 48% reduction in risk of death with a significant p-value. So the secondary and exploratory endpoints. So we can see even though not available in both the groups, we can see the hazard ratio is around 0.39 in case of time to cytotoxic chemo. For the time to PSA progression is 0.26 and the PFS2 is 0.66. Also, you can see at the 24 months event-free rates, the PSA progression is 75 versus 36%, and the PFS2 is 81% versus 72%. So this is the fatigue intensity, the red line being the placebo and the blue one apalutamide. You can see there are more or less overlapping, and the addition of they concluded that the addition of apalutamide to ADT did not increase any fatigue. So these are quality of life indices. Again, we can see there are overlapping more or less. So again, the health-led quality of life was preserved with the addition of apalutamide to ADT. So these are safety data. We can see the grade 3-4 side effects were seen in 42% versus 40%. In those, serious side effects were seen in around 19.8 versus 20.3. And around those led to discontinuation is 8% versus 5.3. And the toxicities leading to death was 1.9 versus 3.0. So more or less no major differences. The most common adverse events being rash, fatigue, fall, hypothyroidism, fracture risk, and seizure. So in case of rash, grade 3 were 6.3 versus 0.6. So in case of fracture, it's 1.3 versus 0.8. And rest were more or less same in both the arms. So again, apalutamide plus ADT in clinical subgroups of metastatic CS PC. So the subgroup analysis as per the synchronous, metachronous, high and low volume disease. In case of synchronous high volume disease and also synchronous low volume, you can see the benefit is equally evident across all the timelines. So hazard ratio is 0.68 here with high volume disease and 0.65 in the low volume disease with synchronous metastasis with very significant p-value here. So here it is crossing the median here. So apalutamide plus ADT OS benefit is consistent irrespective of the high volume or low volume disease. Again, for the PFS in the same high and low volume, you can see the p-value significant here with hazard ratio of 0.51 and 0.38 with significant p-value again. And the apalutamide plus ADT PFS benefit was consistent irrespective of the disease volume. So again, the four subgroups, synchronous, metachronous versus high and low volume. You can see the hazard ratio is 0.4, 0.26, 0.30, and 0.18. So equally, the apalutamide plus ADT delays the time to castration resistance irrespective of the high or low volume disease, favoring especially the metachronous low volume, having the best of the responses. Again, comparison between triplet and doublet. So they're just comparing the only hazard ratio, not the exact survival times. So in case of the triplet regimens like ADT, docetaxel, darolutamide, ADT, docetaxel, abiraterone, ADT, docetaxel, and enzalutamide, you can see the hazard ratios were to the tune of 0.68, 75, 0.57 and all. So again, the same case with apalutamide doublet plus ADT versus placebo ADT. The hazard ratio was in the tune of the same range, that is 0.65 to 69. So they're saying that the hazard ratio for overall survival is similar to the triplet regimens. Again, a deep, rapid, and durable PSA decline with this regimen is associated with longer survival and improved clinical outcomes in this trial. So we can see here the overall survival in those who achieved a rapid PSA decline compared to those not achieved. You can see the hazard ratio is 0.35. The survival is very good in those who achieved a rapid PSA decline with a good p-value. Again, the radiographic PFS is also significantly better in those who achieved a rapid and deep PSA decline compared to those not achieved, with hazard ratio of 0.44 and a good p-value. So this combination demonstrated robust PSA decline that was associated with a improved radiographic PFS and OS. Again, time to PSA progression and time to castration resistance. Again, similar better benefits in those who achieved a rapid PSA decline with hazard ratio of 0.31 in case of time to PSA progression and HR of 0.38 in those with time to castration resistance. Again, the combination demonstrated robust PSA decline that was associated with improved time to PSA progression and time to development of castration resistance. Again, PSA reduction and the long-term benefits. Achievement of deep PSA decline at landmark 3 months of apalutamide treatment was associated with a longer OS, hazard ratio of 0.35, longer radiographic PFS, hazard ratio of 0.44, and time to PSA progression of 0.31, and time to castration resistance of 0.38, compared to no decline at all with a significant p-value. Similar results were also observed at landmark 6 and 12 months. So deep PSA responses is more than 90% PSA reduction, or PSA less than 0.2 nanogram per ml. So the same, the rapid decline is associated with significant clinical outcomes, including long-term survival. So in ESMO 2023, so they're saying the effect of rapid ultra-low PSA decline in Titan patients with CSPC who received apalutamide plus ADT. So the analysis included again around 525 and 527 patients receiving apalutamide and placebo respectively. Two groups of ultra-low PSA was defined. Though ultra group 1 having PSA between 0.02 to 0.2 and UL2 having PSA levels of less than 0.02. So you can see the apalutamide denoted by the blue bar and the placebo with the green bar. We can see across all the timelines and ultra low PSA levels, apalutamide has better responses compared to the placebo. Higher percentage of patients achieved UL1 and UL2 with apalutamide as compared to the placebo. Again, the hazard ratios, the ultra-low PSA decline and the clinical outcomes. We can see across different categories that OS, RPFS, castration resistance, and time to PSA progression. We can see those who achieved ultra-low PSA level, that is UL1 and UL2. We can see the hazard ratios were better with UL2. Those who achieved the lowest level of PSA, the 0.46 versus 0.24, 0.54 versus 0.28. 0.56 versus 0.2 and 0.51 versus 0.11. So significantly showing that the lower the PSA level achieved has the better and long-term survival compared to those who achieved the ultra low level 1, compared to again those who haven't achieved. So the clinical outcomes were better in those achieving ultra low 2 levels. So to conclude the Titan trial, in patients with the CSPC, the addition of apalutamide to ADT significantly improved the survival in the form of RPFS 52% reduction and OS 35% reduction risk of death. And the response to apalutamide plus ADT was consistent across the subgroup, and the patients achieving a 90% or greater reduction PSA from baseline has greatest probability of long-term benefit. Again, rapid, deep, and durable PSA decline is again significantly associated with the better clinical outcomes, including long-term survival. Also, apalutamide was very well tolerated and with adverse event consistent with the previously reported data. So PSA 90 response, that is apalutamide versus Enza or abiraterone. So what is the PSA 90 response? A deep response, or defined as more than 90% decline in PSA, is an important early prognostic factor for achieving radiographic PFS and OS in patients with CSPC. So in this data, the median time to PSA 90 was 3.1 month for apalutamide versus 5.2 months for enzalutamide. So initiation of APA, apalutamide leads to significantly more patients achieving a deep PSA response more rapidly than patients who were initiated on enzalutamide. You can see here again the orange one apalutamide and the brown for enzalutamide. You can see the p-value difference is also seen for achieving the PSA 90 cutoff. Again, this is the graph showing the apalutamide versus abiraterone. So we can see across the different timelines, more patients are achieving better response rates with apalutamide compared to abiraterone, which is denoted by blue and green bars.
So sorry for intervening. Need to conclude, please, sir.
Okay, fine. So basically, apalutamide data is showing even the retrospective data. It is showing better response for apalutamide versus abiraterone and enzalutamide. Again, the similar real-world data for retrospective analysis showing better responses with apalutamide versus abiraterone. Again, the same real-world OS retrospective data showing better response with apalutamide versus enzalutamide at 24 months cutoff. Thank you.
I think yes, your last slide shows the most important thing. Burning question whether when we have a long-term experience of using abiraterone and enzalutamide, so how difficult or easy it is to change your practice when the new data comes in, especially in terms of toxicity and cost. So although we are not going to get head-to-head data, but definitely this whatever data we can get with the cross-trial comparisons will help us to guide the treatment for our patients. So, what percentage of patients have you started using apalutamide in place of abiraterone or enzalutamide?
So recently, I have two patients started recently. So otherwise, earlier it was all abiraterone plus enzalutamide.
Okay. And how's your experience with that, sir?
Till now, they're doing great, so tolerating well. So not nothing much of side effects right now.
Okay. Okay.
It's just 1.5 month follow.
Okay. Thank you so much, Dr. Trivikram.
Welcome.
I think I was mute, sorry. So, moving on to the next abstract, which is a very important topic, that is the use of pembrolizumab in the adjuvant setting in the clear cell RCC. And we have a very important data, that is a 5-year follow-up update from the phase 3 Keynote 564 trial. So, to deliver this, we have with us Dr. Ulfa Tara. She's an assistant professor in Department of Medical Oncology at Sher-e-Kashmir Institute of Medical Sciences, Srinagar. So, over to you, ma'am.
Good evening, everyone, and thanks a lot for making me a part of this academic feast. As we know that pembrolizumab in the adjuvant
Ma'am, sorry for intervening. There's a too much echo from your side. Have you joined from the two devices, ma'am?
No, I have joined only from one device. I have joined from only my MacBook.
It's showing, ma'am, that you have logged in from two devices. That's why it's a lot of echo is there.
Support team, kindly remove the second one.
I've joined only from the one device only. I'll try to.
Yeah, it's okay now, ma'am. Please go ahead.
Ma'am, you are muted, ma'am.
Adjuvant. Good evening.
Hello from tech team. Hello.
Hello.
Yes, sir. Clear now.
Clear.
Okay.
Okay,
Yeah.
please, ma'am, go ahead.
Okay. Basically, adjuvant pembrolizumab in renal cell carcinoma was approved in November 2021, but still we're skeptical about the benefits of pembrolizumab, which subset of patients we should choose in renal cell carcinoma for adjuvant pembrolizumab. Next slide, please. The key takeaway from now the 5-year data follow-up from the adjuvant setting use of the pembrolizumab in clear cell carcinoma. Now we know that besides the DFS benefit which was initially demonstrated, we have an OS benefit data also available with us now. And the safety results have remained consistent with the prior analysis of DFS advantage data. And these results continue to support the use of the adjuvant pembro as a standard of care for patients with clear cell renal cell carcinoma, which are at the high risk of recurrence. Next slide, please. This Keynote 564 was a well-designed trial, and we know the eligibility criteria they have put in, that the patient should not have received any prior systemic treatment, and surgery should have been done less than 12 weeks prior to randomization. And then they categorize the patients into intermediate to high risk, and then high risk, and then very high risk group. The intermediate to high risk group patient comprised of T2 disease with grade 4 or sarcomatide features, and T3 any grade. And then high risk were T4 and the nodal positive disease. Very high risk were the M1, no evidence of disease, that is metastatic patients with single soft tissue met that was resected either at the time of primary tumor resection or within the 1 year of the treatment of the primary tumor. And this very high risk group was also included. And the best benefit was, in terms of the DFS, was demonstrated in intermediate to high risk group. However, all groups were found to have a benefit. And this trial included the patients who had a performance status of 0 and 1. And this trial had this US versus non-US population as well. 496 patients were allocated to the adjuvant pembro arm. The pembrolizumab was given for about 17 cycles. The total duration of treatment was median was 11.1 months and 1 year. And the placebo arm very well matched with the pembro adjuvant arm. And the primary endpoint was initially the DFS, and now the key secondary endpoint was the OS. Now we have a mature 2025 data for OS benefit in the adjuvant setting use of the pembro in clear cell carcinoma. Next slide, please. If we consider these two graphs, we can appreciate that the DFS benefit starts too early, and the two curves are separated throughout. So the DFS benefit is persistent, with pembro having events only 188 and placebo 241. Among the 496 patients which were recruited to pembrolizumab, 290 patients continued to receive the treatment, and 190 patients actually had dropout because of other reasons. We can see that the DFS benefit and the hazard ratio is 0.71. And the DFS benefit, what they had found in this trial, was across all the groups, especially in the intermediate to high risk group. The benefit was very high, and the M1 NED disease benefited less. But the patients who had sarcomatide features as compared to non-sarcomatide had lesser benefit, but all the subgroups actually had benefit. And this category of patients, the surgical treatment that they had received in this trial, complete nephrectomy was given to 92% patients and partial nephrectomy to 8% patients. Since the intermediate to high risk comprised the most common subgroup of the trial, 86% of the patients, and high risk comprised of 8%, and M1, no evidence of disease, they comprise approximately 6% of the patients. Next slide, please. So we can see the DFS benefit in almost all the subgroup of patients. However, hazard ratio was for sarcomatide group only 0.56, and without sarcomatide, it was 0.75. Grade 4 histology, it was hazard ratio 0.65, and M0 high risk 0.61 only. And with no evidence of disease in metastatic patients, it was 0.48, and intermediate to high risk, it was 0.75. However, from this plot, we can really appreciate that every subgroup of patients had a benefit. Next slide, please. Then now we have an updated OS data. These patients have been followed beyond the trial, which was actually closed in December 2020, and then 2023, and the latest update now by 2025. Since initially the adjuvant trials were done in different settings, like giving adjuvant sunitinib, giving adjuvant sorafenib, then atezolizumab, then nivo plus epi. The nivo plus epi found a DFS benefit in a subgroup of patients who had sarcomatide features and low hemoglobin. Rest all the trials failed. So this trial is key in the adjuvant treatment of pembrolizumab, and we can see that the OS benefit started at 15 months approximately, and the two curves continued to be separated, so the OS benefit is persistent. Although we have events in the pembro arm 68 and the placebo 99 events, and the median OS that was not reached in the pembro as well as this placebo arm, but we know that there is a difference in the OS approximately for 5-year data now we have available, and the OS has been found to be in high risk group to be 0.86, and with M1 NED 0.36, and sarcomatide and not sarcomatide histology did not show any difference as far as the survival benefit is concerned. And now we have a mature 72-month OS data with adjuvant pembrolizumab showing the OS benefit 86% and placebo 79%, 32% reduction in the risk of death. And this is an achievement as far as adjuvant treatment of pembro is concerned. Initially, we were concerned that the trial only showed the DFS benefit, but the long-term follow-up has now cashed upon OS benefit as well. Next slide, please. So this is the OS benefit again across the all subgroups. We can see that whether sarcomatide, non-sarcomatide, high risk, no evidence of disease, intermediate, or with CPS score difference or performance status 0 and 1, we know that there is definitely certain subgroups which will benefit more, but overall, all subgroups have shown a benefit in terms of OS as well. Next slide, please. Now we actually are concerned with the recurrence and the subsequent treatments. We know that as far as pembrolizumab is concerned, we consider the early recurrence, intermediate, and the late recurrence. That is within 6 months, and then post-completion within 6 months, and then more than 6 months post-completion of pembro, which we consider as the late recurrence. And then we see that if you consider the pembro arm and the placebo arm very well matched, the different modalities of the treatment that they receive in the form of systemic plus local in the form of surgery or radiation, or surgery or radiation only and no subsequent, they are very well matched. And we can see that the subsequent VEGFR inhibitor has been received in 59% in pembro arm and placebo 58%. However, the further use of adjuvant or metastatic condition, whatever it is, we know that once we have exposed the patient to an adjuvant pembro, the chances of giving PD, this again inhibitor, decreases depending upon the recurrence, as I mentioned, early, intermediate, and late recurrence. So that is one concern. Next slide, please. This is the summary of the updated safety findings. As far as adverse events are concerned, also we know that the grade 3 to 5 adverse events are higher in pembro arm, that is 32%, as compared to the placebo 17%. Overall, we can see that the adverse events, it is 96% versus 91%, and death has been reported in pembro arm in 0.4% versus placebo 0.2%. So treatment discontinuation of immuno is higher naturally because of the certain adverse events which are typical to the immuno. That is 20.7% and 11.5% placebo. But overall, if you consider what we have found in the DFS trial and now updated follow-up data for OS, we can see that the treatment side effects have comparatively remained the same. And we know that the immunological side effects that is expected to be higher in the pembro arm. Next slide, please. So frequency and duration of the grade more than 3 adverse events, that is more than 1% evidence in either arm. We know again, there are certain side effects which are typical for pembro, like any grade, this like hypertension is slightly higher, 2.9%. And in the placebo also, you can see it is 2.6%. So if you compare all these side effects, reasonably we can say that there are certain subsets like autoimmune side effects like getting myocarditis, myasthenia. These tend to be higher in the pembro arm. And there are certain patients which will get side effects more than 3 months after the use of pembro. And but these are still, you can say, as far as the benefit is concerned, within the benefit ratio still is higher as compared to the adverse events. Next slide, please. So in summary, we can say that adjuvant pembro, it still continues to demonstrate improved DFS, and now the OS data is also with us for a 5-year follow-up data. And the DFS and OS benefits of pembro remain consistent in the intent to treat population and across all the subgroups. DFS data, we have seen that 60.9% versus 52%, and OS data is 87 versus 82%. And now we have a 72-month data also available recently, the 2025 update. So adjuvant pembro, as we have classified the groups, intermediate to high risk, and M1 NED, which is very high risk group. And we know that the best benefit is in the intermediate to high risk group, where it is a category 1 recommendation, and where in other subgroups it is a category 2A recommendation. However, all the subgroups have benefited. So, and considering the histology, both sarcomatide and non-sarcomatide have found benefit, but sarcomatide, as far as DFS is concerned, is slightly lower. But in OS data, the sarcomatide and non-sarcomatide have been almost comparable. And with pembro arm, the local recurrence has been 15%, and in the placebo it is 20%. As far as distant recurrences, it is in the pembro arm 88%, and in the placebo arm it is 85%. So with the majority of this data, we are now confident enough to select a subgroup of the patients which we have to offer pembrolizumab in the adjuvant setting with a proper patient profile and explanation of the certain grade 3, grade 4 adverse event which are slightly higher in the pembro adjuvant arm as compared to the patients who are in the placebo arm. Overall, we have now got the OS data maturity, which has actually strengthened our confidence in using the adjuvant, this pembro, in RCC patients, which was a long-awaited, data, because DFS was already with us. But now with OS data, we are confident enough, and we have to select the patient population properly. Next slide, please. And basically, the goal of this study was to find the subset of RCC patients who live longer without the cancer coming back, and when they receive pembro immediately after surgery, because after surgery it should be at least more than or equal to 4 weeks, and the margins should be negative. I previously also mentioned whether it is complete nephrectomy or partial nephrectomy, both are offered adjuvant treatment. Although the trial include mainly the complete nephrectomy patients, 92%, and partial only 8%. And sarcomatide was actually 11% of the total trial population, and mainly the male population, it was 71%. Performance status 0, most of the patients were the performance status 0, so it was 85% patients, and 15% were almost performance status 1. T3 patients were mainly 89% of the patients in the trial. I mean, this is just to mention which subgroup of the patients have actually benefited slightly higher as compared to the other subgroup, although the benefit was across all the subgroups. So it is a treatment of choice now in the adjuvant setting. And even after 5 years of treatment, people continue to have benefits with this treatment, and especially in the terms of OS now, and no new serious side effects have been found. And after 5 years of data, it continues to show that using pembro immediately after surgery may help treat RCC. That has especially a higher chance of coming. Thank you.
Thank you so much, Dr. Ulfat. Indeed, it's a very important topic because initially all were very skeptical and thinking whether to give adjuvant immuno or not, and if not, if the patient progresses, what to do later. But a long-term follow-up of this trial have shown us and given us a confidence that yes, even in spite of all the crossovers, we at 5 years we still have a good OS benefit in terms of numbers as well as statistically significance also.
Yes.
So definitely, I still believe that it's not for all comer. We should select our patients who are at high risk of recurrence and would benefit more from adjuvant use of pembrolizumab. And we'll see over time that how the data evolves with further next immunotherapies as well. So thank you once again. Moving on, we have another abstract from the ASCO, which is about the SHORE 2. It's a phase 2 open label study, and it's the use of neoadjuvant sacituzumab govitecan along with pembrolizumab, followed by the response and adapted bladder sparing and adjuvant pembrolizumab in patients with muscle invasive bladder cancer. So we have seen a lot of newer strategies in muscle invasive bladder cancer, and it is one among this how to use the combinations of ADCs and immunotherapy and how to guide treatment according to the responses. So to deliver that, we have with us Dr. Pravesh Dhiman. He's an assistant professor in Department of Medical Oncology at AIIMS Bilaspur. Dr. Pravesh, over to you.
Thank you, sir. Thank you, Dr. Ankit, for giving me the opportunity to deliver this talk. Can I request to share the slide from your end? Is it possible to share the slides from your end?
Petty, can you please share the slides?
So I will be presenting and I will not be taking much time because it is quite late and much time has passed. So these are the first results of SHORE-02, a phase 2 study of neoadjuvant sacituzumab and pembrolizumab, followed by response adapted bladder sparing and adjuvant pembrolizumab in muscle invasive bladder cancer. Next slide, please. So next slide, please. Yeah. This clinical trial design was the inclusion criteria was age more than 18 years and histologically confirmed T2 to T3B lesions and predominantly urothelial carcinoma histology, ECOG PS of 0 to 1, and those patients who were ineligible or refusing neoadjuvant chemotherapy or this chemoradiation. And so as a trial design, it was 4 cycles of sacituzumab, day 1 and day 8 at 7.5 mg per kg, and pembrolizumab 200 milligram IV and day 1. And after 4 cycles, they were assessed for radical cystectomy or transreductal resection based on the MRI findings, and followed by 13 cycles of every 3 weeks of adjuvant maintenance pembrolizumab. And then after, there are 24 months follow-up every 12 weeks post-surgery. So primary endpoints were clinical CR and this surgical, that is a post-neoadjuvant, but was a pathological response. Secondary endpoint was event-free survivals and this metastasis-free survival and bladder invasive event-free survival and OS neoadjuvant. So next slide, please. So other primary endpoint was complete clinical response rate, and statistical consideration was CCR of less than or equal to 30% as a this null hypothesis, and alternative more than 45% of H1. And it was stage 2 stage 2 design, with the first stage being number being 23, in which the more than 7 CCR were needed. Next slide, please. So initially they screened around 63 patients, and then on enrollment they included 49 patients, and the patients who were evaluable later on were 36. And in these patients, 4 had a disease progression, and surgery evaluable was 32. And we can see the characteristics of the patient. Mainly the white people were included in the study, and other than that, the patients who were ineligible were 7 for chemo RT, and those who refused were 29 patients. Next slide, please. So what were the treatment related adverse events in SHARE 2 study? So we can see that all the if we take together all the treatment related adverse events, anemia was the most common and alopecia was more common. But if we see the immune related adverse events, the most common were thyroid dysfunction followed by a cutaneous rash. So there was not any significant association with the UGT1A1 polymorphism, and there was need for steroid therapy in 7, that is patients, that is 14.3%, and dose omissions were 3 and dose delays were 4. Next slide, please. Next slide, please. So here we can see the interim results of this sacituzumab govitecan plus pembrolizumab. So we can say that these patients 4 patients had metastatic disease. So there was no surgery was offered. But of this patient who were able to undergo radical cystectomy was 9. And in these post-neoadjuvant treatment response are shown like this. One was the TIS, 3 were T2, and T3 was in 3 number of patients were 3. And patient who could undergo re-transurethral resection of bladder tumor was 23. And then the outcome was this post-neoadjuvant therapy. T0 disease was in 16 patients, T1 was in 3, and T2 was 4. So based on these results, the complete clinical response rate was 16 in 16 patients, that was 44%. And the disease after surgery was less than or equal to T1 in 55.6% of the patient. Next slide, please. So when we read the duration of CCR and interim outcomes, we can see the 12-month event-free survival of 71.3%, 12-month event metastasis-free survival was 84.2%, and the 12-month bladder intact EFS was 100% in patients who received a complete clinical response. And bladder intact event-free survival in patients who underwent means again this transvaginal resection of bladder tumor was 74%. Next slide, please. Next slide, please. So what was initially baseline TURBT sample? What was the genomic alterations? Here we can see the patients who were able to achieve the complete cytogenetic complete clinical response were enriched in ERB mutations, and about 40% of the patients have cyclin D complex abnormalities. And if we see the patient who did not receive the complete clinical response, they were enriched in cyclin D1 abnormalities, the cyclin D abnormalities, and the 11% were ERB mutated. So the patients who could achieve the complete clinical response were enriched in ERB mutations. Next slide, please. So here we can see the patients who fared better by gene expression profiling. So TROP2 patients with mRNA expression and MMR signatures were associated with good response. And uh, and next slide, please. So what were the conclusion of these studies? Perioperative sacituzumab immunotherapy revealed compelling complete clinical response rate with a manageable safety profile, resulting in 45% of complete clinical response, allowing bladder preservation without chemoradiation in 74% of the patients refusing radical cystectomy. And this trial provided a safe and effective approach in patients who refuse radical cystectomy at the time of basically evaluation. And interim findings suggest that tumor luminal subtype recapitulated features associated with SG response, and limitations are primarily the interim nature of the results and relatively small number of patients. Next slide, please. So key takeaways as this SGP combination showed an encouraging activity in patients with muscle invasive bladder cancer, and perioperative combination. This combination was safe and effective and resulted in 44% of complete response, allowing bladder saving approach. And there are distinct biomarker features linked to benefit of this combination. Thank you.
Yeah, thank you, Dr. Pravesh. Indeed, it's a very interesting approach upcoming in most of the cancers, including the bladder
Yeah,
one. The combination of ADCs versus IO, the two
yeah,
short treatment modalities being upcoming, and definitely it's going to overtake the genomic instabilities which we see and results in the treatment failure or refractoriness. So we'll be looking forward to these kind of approach, especially the phase 3 trials. Thank you so much.
thank you.
Moving on, we have our third abstract, and that is a subgroup analysis of the NIGRA trial. And for that, we'll be discussing the additional efficacy and the safety outcomes in the exploratory analysis on the impact of PATH-CR and long-term outcomes from the NIGRA trial. And for that, we have Dr. Akansha Chhabra, who is a medical oncologist and met-oncologist at American Oncology Institute in Ludhiana. Over to you, Dr. Akansha.
Thank you, Dr. Ankit, for the wonderful. Uh, am I audible? Hello?
Yes, yes, you are audible.
Yeah, thank you, Dr. Ankit, for the wonderful opportunity. And so today I'll be discussing about additional efficacy and safety outcomes and an exploratory analysis of the impact of PCR on long-term outcomes from the Niagara trial. So just to reiterate, the Niagara trial is all about assessing the efficacy of durvalumab in the perioperative setting. So which we have already discussed in the few slides, and we have already seen that in Niagara trial, the addition of periop durva to neoadjuvant chemotherapy, it demonstrated statistically significant and clinically meaningful improvement in the event-free survival as well as the overall survival. If you look at the Kaplan-Meier curve over here, so you look at the Kaplan-Meier curve, it shows that 2-year event-free survival was improved from 59 to 67% in favor of the durvalumab arm with a hazard ratio of 0.68. Also, the overall survival was also improved with a hazard ratio of 0.75. There was also improvement in the PATH-CR rate to the tune of 10% with the addition of durvalumab in the perioperative setting in the Niagara trial, and there was no patient who led to delay to the surgery, and there was no impact on the patient's ability to undergo the complete surgery. So this was all about the Niagara trial, but today in this presentation, we'll discuss about the additional efficacy and safety results from the Niagara trial. So this was the study design, which was very simple, where cisplatin eligible, non-metastatic muscle invasive bladder cancer were taken from stage clinically T2 to T4A, either node negative or node positive, and both urothelial carcinoma and the other histological subtypes were taken, and the crack clearance of more than 40 was required. So around 1000 patients were taken and they were divided into 1:1 arm. One arm received durvalumab plus gemcitabine cisplatin chemotherapy. Durva was given at the dose of 1500 milligram 3 weekly. Although in the trial, Gemcis in the split dose, that is day 1, day 8, was also allowed. So after 4 cycles, patient underwent radical cystectomy and they achieved adjuvant durvalumab to complete total of 1 year. This was compared to Gemcis alone, followed by radical cystectomy. We have already seen the primary endpoint results, that is, there was improvement in the event-free survival and PCR rate by 10%, and also there was improvement in the key secondary endpoint, which was the overall survival, which was improved with the addition of durvalumab. So here today we'll discuss about the secondary endpoints, that is metastasis-free survival, disease-specific survival, the safety events, and the exploratory post-hoc analysis of EFS and OS by PCR. So these were the results. In intention to treat population, the metastasis-free survival was improved. If you look at the 2-year timeline, 2-year EFS metastasis-free survival was improved from 65 to 75% with a delta of 10% with a hazard ratio of 0.67 in the favoring the durvalumab arm. It means that the addition of perioperative durvalumab, it reduced the risk of distant metastasis or death by 33%. Again, if you look at the disease-specific survival, the 2-year DSS was improved from 82 to 89% with a delta of 7% and hazard ratio of 0.69. It means that addition of perioperative durvalumab to neoadjuvant chemotherapy, it reduced the risk of death from bladder cancer by 31%. So if you look at the PAT-CR rate, it was improved from 27 to 37%, means there was additional 10% improvement in the PAT-CR with the addition of durvalumab. So then these patients were further divided into 2 subsets. One subset was the patients who achieved PCR and other subset was the patients who did not achieve PCR. Again, the patients in these 2 categories, they were separately divided and they were the baseline characteristics were matchable in these groups. So the median age was 64 to 65 years with majority of the male patients. Both Asian and non-Asian population were taken. At least CRAT clearance of more than 40 was required and histology either urothelial carcinoma or divergent and other histological subtypes were taken. Majority patients were node negative, although few patients were taken which were node positive. PDL1 was done by the Ventana platform and the majority patient had TC of more than 25%. Although 20% of the patients also had TC of less than 25%, they were also included in the trial. So we know that the patients who achieve PCR, they have better EFS than the patients who do not achieve PCR. But in these patients who achieved PCR or in patients who did not achieve PCR, Durva performed better. How? You can see the Kaplan-Meier curve that in patients who achieved PCR, event-free survival was improved from 85 to 92% in favor of the Durva arm. And in patients who did not achieve PCR, EFS was improved from 49 to 53% with a hazard ratio of 0.68. It means irrespective of the patients achieving PCR or not, durvalumab performed better and is of benefit in the subset of patients in the perioperative setting in the urinary bladder carcinoma. So coming to the overall survival in patients who achieved PCR, it was 2-year OS was increased from 91 to 95%. And in patients with non-PCR, it was improved from 65 to 74% with the hazard ratio of 0.75, again favoring the durvalumab plus neoadjuvant chemotherapy arm. So coming on to the adverse events. So the grade 3, grade 4 events were to the tune of 69%, but they were equal in both the arms, meaning that the majority of the adverse events were due to chemotherapy rather than due to immunotherapy. And there was no patient in the durvalumab arm which led to delay in the surgery or patient not undergoing radical cystectomy or patient discontinuing the neoadjuvant chemo, means that addition of durvalumab did not show any additional safety signals. The immune-related adverse events were mainly thyroid-related, that is hypothyroid followed by hyperthyroid. 1 or 2% patients, they also had dermatitis, renal events, colon events like colitis or diarrhea, and lung-related events, that is pneumonitis. But these were only to the tune of 1 to 2% with further less in the grade 3 or grade 4 events. And the majority patients who had adverse events was hypothyroid, but that was well manageable with the replacement therapy. So to conclude, Niagara demonstrated statistically significant and clinically meaningful improvement in both event-free survival and overall survival, along with the improvement in the pathological complete response to the tune of 10%. In the durvalumab arm, the risk of metastasis-free survival was reduced by 33% and risk of disease-specific survival event was reduced by 31%. Periop durva plus neoadjuvant chemo improved the event-free survival and overall survival in both patients either who received PCR or non-PCR groups in the exploratory post-hoc analysis, and immune-related events were mostly low-grade, and we know what are the side effects of durvalumab. There were no new safety signals. Whatever events were there, they were well manageable. So to conclude, this additional Niagara data further supports the periop durva with neoadjuvant chemotherapy as a potential new treatment for patients with cisplatin eligible muscle invasive non-metastatic bladder cancer. So thank you, organizer, for giving me this wonderful opportunity, and back to the organizers.
Yeah, thank you, Dr. Kancha. Indeed, this subgroup analysis gives us the confidence that how important it is to achieve a PATH CR and to obtain survival benefits with that. So definitely, we were previously thinking the strategies to use adjuvant immunotherapy. So this subgroup analysis highlights how important it is to use the perioperative one.
Also,
So
if you
thank you
use
once.
the adjuvant immunotherapy, none of the trials has shown overall survival benefit. This is the
Yes.
only trial which has shown the OS data and beneficial also.
So that's because of that only, because we have a better tumor control, better PATH-CR rates, which has resulted into the overall survival benefit. Yes, I agree with you. So moving on to not from the drug parts to the delivery part. We know that the drug is very important, but the delivery is also very important. And to make it convenient, the journey of the cancer patients, we have a session on choosing the right central venous access device that is on the pick line. And for that, we have Dr. Avriti Baveja with us. She's a associate professor, Department of Clinical Hematology at HIMSS Dehradun.
Thank you very much, Dr. Ankit, for providing me this opportunity. Now I'm sharing my slides. So are my slides visible?
Yes, ma'am.
Thank you. So the background for this topic, we all know that venous access is critical for all cancer patients, and both chemoport and PICC lines have their place in the mix. Irrespective of the individual preference, some patients are best suited for one and not the other. So we'll understand the global guidelines related to the PICC line, understand the Indian practice
Ma'am, we can't hear you. Hello?
It's a network issue.
Yes, yes.
I'm really sorry I lost the connection in between.
Sure, ma'am.
So, although venous access may seem a minor thing, but it dramatically affects the patient's ability to receive appropriate treatment. So, do we need an Indian algorithm on how to use PICC lines in our cancer patients? So, the answer is definitely yes, because the awareness is lacking. We are not making full sense of training opportunity and material. We may have a casual approach, dedicated venous access teams need to be strengthened, and several unique Indian experiences has led to unique solutions.
Please make it full screen.
Yeah. I'm doing. So lack of venous access may prevent continuum of chemotherapy for our patients. 70% of the patients receiving irritant vesicant chemotherapy experience phlebitis, and 22% of the patients receiving irritant vesicant chemotherapy experience extravasation. This is a very surprising thing for us. And for this, we need to understand the global guidelines. Most of the time, there are various guidelines for deciding on the venous access approaches. The magic approach, in which the peripheral IV cannula and ultrasound guided peripheral IV cannula should be used up to 5 days. Midline catheters and acute central venous catheters should be used for critically ill patients, and PICC line tunnel catheters and ports are the options for cancer patients receiving chemotherapy. So as per the algorithm, PICC line is good for irritant vesicant infusions if for short duration, maybe for 6 to 14 days, even for 15 to 30 days, and even for more than 30 days, PICC lines are a preferred choice. Then frequent phlebotomies, PICC line can be used in all the durations. Tunnel catheters are good if the duration of infusions is more than 15 days, and port is good if it is being used for more than 30 days. So creating an algorithm depends on various factors. For example, type of infusates and chemotherapy, expected duration of treatment, and indwelling time of venous access device, intensity of dose, vascular integrity of the patient appropriateness, and any other. Most of the time, finances are again a choice, because in Indian scenarios, most of the time patients, they don't want to get a PICC line in the very beginning because of the cost issues in at various centers we come across, because most of the time therapies are being provided by various schemes, but lines can be a problem for some of the patients. So what percentage of your patients receive chemotherapy of short infusion and less than 6 cycles need to be reflected? Then CT of longer duration and IV maintenance up to 12 months. Do we need to think about the lines and chemotherapy plus infusional monoclonal antibodies or immunotherapies? Most of the chemotherapy agents are either vesicants, irritant, or both. So the vesicant agents could be anthracyclines, vinca alkaloids, and alkylating agents, and irritants are DNA intercalating antibiotics, antimetabolites, alkylating or DNA binding agents, etc. So considering CVAD for all vesicant and irritant drugs should be done to avoid any vascular complications, so as to prevent extravasations and thrombophlebitis, and avoiding frequent pricks for phlebotomy. On the basis of the Indian data, which we got to know that in 70% of the cases, PIVs are still being used for irritant and vesicant medication, and that is really alarming. PICC line sports, CVCs are being used only in 30% of the cases. PICC lines are recommended for the administration of irritant and vesicant chemotherapy. There are certain guidelines which support its use. For example, the MAGIC INS. One PICC line may be one prick in the patient's treatment journey if we take the if we take the decision of insertion of PICC line at the right time, and we are able to maintain and take a good care of the PICC line for a long duration. considering the ASCO guidelines, the NHS guidelines, the MD Anderson Cancer Center guidelines, PICC line is intended for patients requiring up to 12 months of IV therapy. PICC indwelling time ranges from 7 days to 34 months. In most scenarios, a PICC line can be cited for treatment lasting few days to many more years in the NHS guidelines. So there are 4 international authorities which are saying that PICC lines can be used for a duration for 12 to 34 months if a good care of PICC line is taken. PICC lines are typically used for therapies that have a duration of 2 weeks or more and have a good indwell time. In solid malignancies also, in India, several centers have used PICC lines for 12 months to 18 months. So do we ever estimate what the patient will go through during the expected journey of systemic therapy in terms of number of pricks, lines of therapy that patient might get? For example, even in solid malignancies, for hematological malignancies, it is known that it is for a long duration. But for malignancies, for solid tumors, maybe lung cancers, ovarian cancers, patient invariably will receive multiple lines of infusional chemotherapy, including platinum therapy. So these are the hypothetical case studies in which in NSLC without any driver mutation patient was required 3 lines of chemotherapy. That means 72 pricks in a year. And even again, this is a 58 years old cancer ovary patient with multiple comorbidities. In this also, the patient received 3 lines of chemotherapy, and thus it becomes very difficult to get a good access in various chemotherapies, and it produces a good amount of mental trauma to the patients as well. So understanding the barriers. In Indian studies, even with PICC lines, there has been a good median catheter indwelling period. And if we talk about the cost comparison, if we are comparing the cost which is involved in the care related to the complications associated with the extravasation, that is more than the cost of the PICC line. And training a nurse for PICC line insertion can be a very cost-effective thing, because if we train our nurses, the cost reduction can be reduced by 60%. The insertion rate can increase by 91.6%, and the complication rate shall reduce to 3.8%. So USG guided insertion reduces all the complications which are related to the insertion, for example, mechanical complications, infections, thrombosis, and thus making PICC line a cost-effective access device. So what is the current status of PICC line insertion and care at your center? We need to reflect on that. Is that leading to high incidence of complications and premature removal? So we need to reflect on points like, do we have a dedicated PICC line team? Are we using USG guided PICC line placement? Are we educating the patients and caregivers for the proper care of the PICC line? And are we training the nurses with the help of various teams like BD also provides services for teaching PICC lines to the nurses and PICC line care to the patients as well as to the staff? So how is the patient compliance in terms of weekly dressing and flushing? What is the percentage of your patients requiring premature removal of PICC lines due to complication, and what measures can be taken to improve the compliance and reduce the complications? So to summarize, CVAD is recommended for all vesicant and or irritant drugs, for chemotherapies which have a pH less than 5 or more than 9, infusates with osmolarity more than 600 milliosmoles per liter, for TPNs, blood and blood products. Then we need to make a habit of formally checking venous status for every patient who will be starting chemotherapy. Every center must provide option of chemoport and PICC line to the patients. Contrary to the common misconception, PICC line has been successfully used for short, intermediate, as well as long-term therapy, and benefits merit the use of PICC line therapy. So, thank you. Now I hand over to the organizers.
Yeah, thank you, Dr. Avriti. Indeed, the use of PICC line is very, very important when we have long-term patients and multiple pricks and sampling and close infusions are given. So definitely, PICC line usage is very important, but we need proper trained team, including the nurse, to handle and minimize the complications. And with that, the benefit can be passed on to the patients in terms of making their journey, cancer treatment journey very convenient. At last, we have a session on hematology. We have discussed a lot about the solid tumors, including the GI and the GU, but hematology is one of the core aspects of the oncology. And for that, we have a session which is sponsored by Pfizer, and that will be about the role of inotuzumab in the evolving treatment landscape of relapsed refractory adult B cell ALL. And to deliver this talk, I request Dr. Avriti Paveja again to have this session.
So, role of inotuzumab in evolving landscape of adult relapsed refractory BLL. Now, again, I want to thank Dr. Ankit for providing me this opportunity and Pfizer for providing me with the slides. So, we need to understand that we all know that the ALL patient journey is very difficult and dramatic. First of all, we have to make the diagnosis, and after diagnosis, we have in cases of newly diagnosed ALL treatment, depending upon the risk stratification, we give chemotherapy to the patient, induction, consolidation, and maintenance. And now with incorporating various NGS approaches, now the management of the patient has become more of molecular driven also in cases who don't land up into remission. And if patient is in remission and then later on patient is relapsed, or if patient is refractory, then we have to consider the options of salvage chemotherapy or inotuzumab or therapies like blina or CAR T cell therapy. So poor prognosis in relapsed refractory ALL patient is the standard of care chemotherapy is very difficult. You know, in our post in our DM days, as a resident, we used to think that whenever we are dealing with a case of relapsed refractory ALL, the patient would hardly survive in the salvage therapy, and without transplant, the rates of recovery are very dismal. So the various factors which confer poor prognosis in relapsed refractory ALL are age, high WBC count, certain cytogenetic abnormalities like MLL, Philadelphia chromosome, late response to therapy, spread to CNS, and there are certain subtypes of ALL according to the genetic mutations which are poorly responsive to the standard chemotherapy. And we also know that as the age of the person increases, of the ALL patient increases, the cure rates also decrease. So we need to switch patients from salvage chemotherapy to immunotherapy in adult BLL scenarios. The journey of immunotherapy, we started with the use of rituximab because of the presence of CD20 positive. Then inotuzumab came into picture where CD22 positivity was being targeted, and in blina, CD19 bispecific monoclonal antibodies are being incorporated in the treatment of BLL. So, inotuzumab is currently indicated as a monotherapy for the treatment of adults with relapsed refractory BLL. And CD22 testing is usually being done in all the flow cytometries these days, and it shows about the CD22 expression and CD22 density. However, studies have shown that even with CD22 low expression, also the patient responds to the therapy. And MRD is being used, so we can decide on the using inotuzumab at early stages also. So the current dosage, depending upon if it is being used singly, is 0.8 in the cycle 1, 0.8 the loading dose, then 0.5 at day 8, and then 0.5 milligram per meter square on day 15. And in the subsequent cycles, depending upon the response, whether the patient has achieved CR or not CR, if CR has achieved, then the second cycle is of 0.5 mg per meter square on day 1, 8, and 15 subsequently. However, the patients who have not achieved CR in those cases, we have to use it in the dose of 0.8, 0.5, and 0.5 respectively. So the recommended cycles are more than, if 2 cycles are recommended if we are proceeding for the stem cell transplant, maximum of 6 cycles if we are not proceeding for transplant, and we have to consider a third cycle if CR and CRI is not achieved and MRD is not achieved after 2 cycles, and discontinue after 3 cycles if CR has not been achieved. So inotuzumab versus chemotherapy in relapsed refractory ALL in the phase through INOVATE trial definitely shows a better survival rate. And we need to understand on the profile before choosing the patients for which we have to choose inotuzumab. Whether we are giving the patient therapy for the first salvage or second salvage, whether the patient is pH positive or pH negative, whether the patient is transplant eligible, or we are using it as a bridge to CAR T cell therapy or a bridge to transplant, or if the blast count is more than 50% or not, post-transplant relapse, or whether we are dealing with an extramedullary disease. So if we talk about the salvage status, it has been seen that if we use inotuzumab in salvage 1, the chances of getting CR responses is approximately 78.4%, and if we use in the salvage 2, it is about 64.7%. Inotuzumab has a good response irrespective of the blast count. In the post-transplant relapse scenarios, the curative potential of allogenic stem cell transplant is usually hampered by relapse. In ALL patients, relapse rates range from 30 to 50%, with most relapses occurring within first year after allo-SCT. Even with extramedullary disease, we can see that 55% of the patients have achieved CR after 2 cycles of inotuzumab. It can be used as a bridge to CAR T cell therapy, and it has been used in 28% patients of CAR T cell therapy has been used in 28% patients of the INO exposed cohort. Even with the Philadelphia positive status, inotuzumab could achieve a good response rate. In transplant eligibility clinic, it has been seen that all cases achieved CR after receiving at least 2 cycles of inotuzumab. Mini CVD with inotuzumab is also a good option in cases if the patient is not willing to go for transplant, and it has shown the CR rates of approximately 33%. Now, which patients are ideal for stem cell transplant? Age less than 65%, 65 years, good performance status, MRD negative status, adequate donors, no prior transplant, and when we have a good social support. The safety profile during the study treatment, 1.8% of the treated patient experienced VOD in salvage 1, and 5.9% of INO treated patients experienced VOD in salvage 2. And following transplant, 19% of the INO treated patient experienced VOD in salvage 1, and 35% of the patients INO treated patients experienced VOD in salvage 2. So we need to be cautious when we are using inotuzumab proceeding to transplant, and we need to work on our conditioning strategy. For example, dual alkylators conditioning regimes were significantly associated with increased risk of VOD. So we should not use dual alkylators. We should avoid hepatotoxic drug agents, for example, azoles in combination with high dose alkylating conditioning regimes. The recommended duration of treatment with INO is usually 2 cycles. Third cycle should be used in desperate cases only when we are not able to achieve MRD negativity after 2 cycles. if the total bilirubin is more than upper limit prior to transplant, it has been seen that it can be significantly associated with increased risk of VOD. Hence, we need to monitor our liver function test closely. We should monitor for signs of VOD. We should be ready for the treatment related to VOD. And it is recommended to give ursodeoxycholic acid to all patients who are receiving inotuzumab to patients prior to transplant. And even in the transplant, we need to give ursodiol to the patients. That may reduce the incidence of VOD. Now, when to choose Blina and when to choose INO? Most of the time, with Blina, we have issues related to logistics, ease of administration, infusions, etc. In that scenarios, INO is a good choice. MRD eradication can be seen with both the drugs. Maintenance or re-challenge can be done for both. Underlying CNS pathology, inotuzumab has got a good role. In liver dysfunction, Blina may be preferred. In prior or future transplant, we can use both Blina as well as INO. When the tumor burden is high, INO does better than Blina. And in case of pH positive BLL, INO could be a preferred choice. In past decade, effective immunotherapies have been developed for BLL, higher response rates and cure rates. Inotuzumab is indicated as a monotherapy in relapsed refractory BLL. INO is highly effective in relapsed refractory BLL, able to achieve CR and CRI of approximately 80% with high rates of MRD negative. It is effective in high disease burden and may be preferred to Blina. Toxicity profile management with appropriate mitigation strategies, and the goal for most but not all patients with relapsed refractory patient is transplant, and we need to identify suitable patients for which HSCT is imperative. Thank you. Now I hand over to the organizers.
Yeah, thank you, Dr. Avriti, for such a lucid talk on the use of inotuzumab in relapsed refractory ALL. We all know that it has been a very significant burden in the pre-era of this inotuzumab, and we were relying only on permutation combinations of different chemotherapies. And in spite of salvage chemotherapies and transplant, the cure rates were very dismal, and cure rates were near close to 10%. But with the advent of newer ADCs and readily available and being within the reach of most of our patients, it is very easy to salvage these kind of patients and make them reach to transplant and save lives. So thank you, thanks a lot. And with that, we come to the closing of our first day of this academic extravagant feast of oncology next. And last but not the least, would like to thank all our sponsors for contributing to this webinar and enriching our knowledges. I hope everyone has learned new things today. We'll meet tomorrow, same time for the day 2, having interesting talks about the updates from ASCO on breast and lung cancer. So with that, I would like to thank you everyone, and good night. And thanks to our organizing team and the tech team for conducting it very beautifully and smoothly.
Thank you so much, sir.
Yeah, thank you everyone. Good night.
Good night, sir.